Bore da, a chroeso unwaith eto i'r cyfarfod yma, y bore yma, sef cyfarfod bwrdd, bwrdd iechyd addysgu Powys. Ac yn ôl ein harfer, fel y gwelwch chi, mae'r cyfarfod yn cael ei prif ffrydio o'n gwefan ni, ac mi fydd na recordiad o'r cyfarfod ar gael i'w gwylio ar ôl y digwyddiad heddiw i'r rhai sydd yn methu bod gyda ni ac sydd eisiau gwylio ein cyfarfod ni ar ôl heddiw. Carl Cooper ydy yn enw I, a fi ydy cadeirydd y bwrdd. It's a real pleasure, as always, this morning to welcome each and every one of you to this meeting of the board of Powys Teaching Health Board. As always, we are live streaming our meeting from our website, and as always, there will be a recording of this meeting available to watch from our website after today for any who want to access our meeting but can't actually join us live during the next few hours. My name is Carl Cooper and I am the chair of the Health Board, ac mewn eiliad neu ddwy, fe welwch chi ar y sgrin, manylion hefyd o ynghydweithwyr bwrdd, sef aelodau annibynnol yn ogystal ag aelodau gweithredol. Ac hefyd, fe welwch chi wybodaeth am fynychwyr ychwanegol fydd yn bresennol yn ein cyfarfod heddiw ac y rhai fydd yn cyfrannu at ambell i eitem ar ein hagenda. Ac hefyd, fe welwch chi enwau cydweithwyr sydd yn methu bod gyda ni heddiw a dyn ni wedi derbyn eu hymddiheuriadau am absenoldeb. So in a few seconds, you'll see on the screen information and details about who we are as a board, my board colleagues, both independent member colleagues and executive member colleagues. Also, you'll see there information about people, additional attendees that will be with us in today's meeting, and they will be contributing to support various agenda items. Also, we do have some colleagues that can't be with us today for various reasons, and we have accepted their apologies for absence. Of course, you will note immediately that our Chief Executive, Hayley Thomas, isn't with us today. And as many people are now aware, Hayley is currently on a period of sickness leave following a cancer diagnosis. And certainly on behalf of all of us, we want to extend our very, very good wishes and our support to Hayley as she prepares for her treatment and as she enjoys a good, swift and full recovery. And certainly we look forward to seeing her when she's able to return to work. But in the meantime, I am equally grateful to Pete Hopgood, our Deputy Chief Executive and Director of Finance, Estates and Support Services, who has now taken on the role of Acting Chief Executive. Also to Dr. Kate Wright, our Executive Medical Director, who has now taken on the role of Acting Deputy Chief Executive, and to Hywel Hullin, our Deputy Director of Finance, who is now acting as Executive Director of Finance. So a big thank you to all of you for stepping into those roles. And Hywel, particularly welcome to you. You've been to board meetings before, but welcome in your new capacity particularly. And can I just say as well, a big, big thank you to the board generally, to the executive team, and to all the organisation. The fact that we have been able to move to these new arrangements so smoothly and seamlessly, I think speaks impressively of the high quality of team effectiveness and the sense of mutuality and resilience that exists within our teams, that of course has been developed under Hayley's executive leadership. And so a big thank you to everyone for your cooperation and your support in putting these new arrangements together. Felly, ni ydy y bwrdd, ac y bwrdd ydy'r corff llywodraethol y sefydliad. Ac mae gen ni pwrpas arbennig, mae gen ni pwrpas pwysig. Ac yn benna, dyn ni'n gyfrifol am 4 cyfrifoldeb. Yn gyntaf, dyn ni yma i osod cyfeiriad strategol ar gyfer y sefydliad. Yn ail, dyn ni yma i osod archwaith risg wrth i ni gyflawni ein hamcanion strategol. Yn drydydd, dyn ni yma i fonitro perfformiad, ein perfformiad ni fel sefydliad yn erbyn yr amcanion strategol hynny. Ac yn bedwerydd, ac yn sicr nid yn lleia, dyn ni yma i osod, i liwio ac i fodelu tôn a diwylliant y sefydliad yn seiliedig wrth gwrs ar ein gwerthoedd. Ac wrth gwrs, yn tanseilio neu hynny i gyd, dyn ni yma i sefydlu ac i gynnal ansoddau uchel iawn o lywodraethiant corfforaethol. As a board, we are the governing body of our organisation. And put simply, we have 4 main responsibilities. We're here to set the strategic direction for our organisation. We're here to set the risk appetite in the delivery of our strategic aims. Third, we're here to monitor performance against the delivery of those strategic priorities. And fourthly, certainly not leastly, we're here to set, to model and to shape the tone and culture of our organisation, which are based, of course, on our shared values. And of course, underpinning all of this is the fact that we are here to establish and to maintain high standards of corporate governance. And so that is essentially what we are here to do. We meet in line with NHS Wales regulations, but as I always explain, although we meet in public, it's important to distinguish between a meeting in public and a public meeting. The only people that will participate in and contribute to our meeting today are board members and those that we have invited to contribute to certain agenda items. However, we do welcome and we do encourage questions from the public for our consideration in these meetings, and information about how you can submit a question for our consideration is available on our website. Yn dilyn y cyfarfod cyhoeddus yma heddiw, mi fyddwn ni yn cynnal ail gyfarfod, ond cyfarfod preifat, ac yn ystod y cyfarfod preifat hwnnw, mi fyddwn ni yn ystyried 3 pheth. Yn gyntaf, cynllunio argyfwng ac adroddiad blynyddol. Yn ail, ein cyflwyniad ni fel bwrdd i Lywodraeth Cymru ar gyfer cymorth gofal wedi'i gynllunio. Ac yn drydydd ac yn ola, nifer o faterion cytundebol. After our public board meeting, we will be holding an in-committee meeting of our board, an in-private meeting of our board, where essentially we will consider 3 items. 1, emergency planning plans and our emergency planning annual report. Also, our submission to Welsh Government for planned care support, and finally, a number of contractual matters. As I often explain in our board meetings, our public board meetings, such as today, are just the tip of the iceberg of the work that we do as a board. A lot of detailed work happens in our subcommittees, in our formal and informal sessions as a board, and of course, as we get out and about and ensure that connectedness with our organisation more generally. And so as we come to various agenda items today, we will be asking for assurance from the chairs of various committees and so on, where those papers have had detailed consideration and undergone detailed scrutiny by those various committees. So, for example, risk management and the Better Together programme that have already had detailed discussions and consideration. Also, and finally, we operate a consent agenda, and a consent agenda is where we list items that we consider to be non-controversial and not to need discussion or conversation today, and therefore we can approve or we can receive or note those items without discussion en bloc. And you'll see the items under the consent agenda in section 4 of our agenda. However, there will be an opportunity very early in our meeting for any board member to ask that any item in the consent agenda be placed on the main agenda as a substantive item for discussion. So we as a board are always in control of what is included and indeed what is not included as a consent agenda item. So that really concludes now my introductory comments, which means that we move to the agenda itself and immediately to item 1.2 on our agenda, declarations of interest. Our standing interests as board members are available and in our register of interests, and that register is publicly available. But colleagues, do any of you want to draw our attention to any conflict of interest that may exist against any agenda item in our meeting today? No one does, and therefore there aren't any additional matters to consider in relation to declarations of interest. That brings us to item 1.3 on our agenda, the board action log, and I'll initially turn to our Director of Corporate Governance, to Helen, and just to ask Helen whether you have any introductory comments in relation to the action log before we open it up for question and discussion.
Diolch Carl, bore da everybody. Helen Bushell, Director of Corporate Governance. So pleased to present the action log to you. Colleagues will see that there are 4 actions on the log currently. 3 of them remain open and on track, and they are in relation to some work in relation to our board work programmes, in relation to our Power of Discharge Committee, and also the People's Experience Framework. And you'll see that some brief updates have been provided. All 3 of those remain on track to come back to board either in September or in November as highlighted. Carl, I am conscious that there's quite a number of updates over a period of time in relation to our People's Experience Framework, and just to confirm, that is on our Patient Experience, Quality and Safety Committee agenda for next week, and is on track to come back to the board in September also. There's one further action that is currently in the recommended for closure box. That's in relation to the air ambulance and the EMERT service, and particularly recommendation 4. There is some information contained within the Chief Executive's report, and Carl, I'm suggesting that the board may want to come back to that action later once you've received the Chief Executive's report and determine whether or not that action can be closed or not. So that's the update from me. Thank you.
Thank you, Helen. Colleagues, please do indicate if you'd like to ask a question. Let's go initially to Ronnie Alexander. Thank you, Ronnie.
Thank you. Good morning. Ronnie Alexander, independent member. Helen, 2 brief observations on this. First of all, in relation to the sampling of decisions by hospital managers in relation to power of discharge committee. I first raised my concerns about this process, I think about a year ago at board, and I know that there's progress. I know that there is a recruitment exercise underway, and I think we're drawing on resources from other organisations in the interim. But sampling can be of two sorts. It can be dip sampling, which is helpful, but only up to a point, or it can be statistically representative sampling, which is rather more useful. So I'd like to be assured, please, that the arrangements around this in the interim are robust, bearing in mind the vulnerabilities of the individuals involved. That's my first point, Helen. Secondly, you've already referred to the patient experience framework. We have 8 updates there. As you know, I have personal concerns when there are a number of updates, because whilst there may be very good reasons for this, it appears that our rate of progress is somewhat slow. So I'd be grateful for assurance on that point as well, please. Thank you.
Thank you very much, Ronnie. Carl, if it's okay, I'll ask Elaine to comment in relation to the power of discharge point that Ronnie's raised, and Paul may want to comment in relation to people's experience framework. What I would just quickly add on people's experience framework, and you're right, Ronnie, we would never ordinarily be comfortable with that number of updates that appear on the log. I think there's quite a long history here whereby we've been waiting for some work that happens nationally, and that reflects some of the earlier time frame, and then, as you rightly say, there's been some areas internally that we've needed to progress. I am content, I've got the paper from Paul, and I am content that that's going into our patient experience committee next week, but Paul may want to add to that after Elaine. Thank you.
Thank you,
Elaine. Bwrdd, good morning everybody. I'm Elaine Lawton. I'm the Executive Director of Primary Care, Community and Mental Health. So in terms of this, I recognise that this has been raised for a while. There have been a number of key parts that we've had to work through. The governance has now been resolved. The recruitment, we have a meeting scheduled for next week where we will pick up and look at that. We do have interim arrangements in place at the moment, Ronnie, with the hospital managers from other health boards, recognising that the role is okay to share in that way. We will now be moving on to the sampling for those decisions that have been made. I'm happy to pick up a separate conversation. You're probably more knowledgeable about survey and sampling techniques than I will be, so I'm happy to pick that up with you. But at present, we recognise the fragility of that team. We've got 5 hospital managers, only 3 of them are able to offer services at the moment. So we are taking forward actions to make sure that we're assured and that we can manage that responsibility of ours appropriately.
Thank you. I just wondered, before we go on, Rhiannon, our Vice Chair, chairs the Power of Discharge Committee. I just wondered, Rhiannon, do you have any additional comment you'd like to make?
I think just to confirm that meeting that Elaine just referred to is one that I've called, and we are seeking resolution on some of the challenges that we have been facing. In addition to that, I have been in contact with hospital managers and also have organised a meeting with them separately outside of the kind of formal arrangements to hear any concerns they may have and to seek to give some reassurance in that space as well.
Thank you, Rhiannon. Ronnie, are you content, or would you like to comment further?
Thank you, Carl. I don't wish to labour the point, but I just wish to make, I think, the observation that I think it's important that we're seen to make substantive progress on this as an issue. Thank you.
Thank you, Ronnie. So we go on to your second question, and who's going to deal with that, Helen?
Yeah, thank you, Carl. So I stand by my comments and the summary that I provided, but Paul, would you like to add anything further?
I think just to reinforce what you said, Helen, and thank you for the question, Ronnie, and absolutely would agree that this has been a protracted exercise of in developing embedding our people experience framework, its associated governance structures and policy, and equally developing and embedding our Civica mechanism for the public and our staff to engage and give their feedback. We are now at the stage that we are bringing to PECS next week our completed framework and policies with a recommendation that that's approved and then brought into board in September. And then I'm hoping at that point we're able to close this action and then get on with embedding the framework over the coming year.
Thank you, Paul. Ronnie.
Thank you. I'm content, Carl.
Thank you so much. Really helpful. Let's go to Mick, please.
Bwrdd Powys, Mick Janassi, independent member. Thank you, Chair. Chair, I do have some reservations about the closure of the EMERTS action. In process terms, I'd be very content to leave that until the Chief Exec's report and just note it at this point. But do you want me to defer it, or do you want to deal with it now?
Shall we deal with it after Pete's report, Mick? Is that okay with you?
I'm very happy to do that. Thank you.
I'll make sure we do come back to you.
Thank you.
Thank you. In which case, I think that concludes our comments and discussions, questions and so on the action log. And so we turn our attention to item 1.4 on our agenda. And we have two experience stories today, a staff experience story and a patient experience story. And I'm going to ask our Executive Director of People, Culture and Transformation, Deb, to introduce the staff experience story to us. Thanks, Deb.
Thanks, Chair. Bwrdd Powys, good morning, everybody. So Deborah Wood-Lawson, Executive Director, People, Culture and Transformation. I'm delighted to introduce today's staff experience story, and we welcome Tom Morris to our meeting. Tom is a member of the Health Board's Estates team and has been for the past 4 years. Tom works in a role that is often behind the scenes, but it's essential to maintain safety, functionality of our buildings, patients, staff and visitors. Today, Tom will provide an insight into his role and the valuable contribution of the Estates team. He will also share details of a wellbeing project he has supported through Chat to Change, which is our staff voice group. I'm grateful to Tom for taking the time to join us today and share his experiences, helping us to gain a greater understanding of the important work being carried out by the Estates team. Welcome, Tom. I'll hand over to you.
Cool. Thank you, Deb. Thank you. Good morning. My name is Tom Morris, and I am the CAD and Property Systems Officer within the Estates Department. Today, I'd like to give you a brief overview of my role, the work I undertake across the Health Board, and how that work supports safe, efficient, and sustainable management of our estate. I'll also touch on some of the opportunities we've embraced through technology and staff engagement, as well as some of the challenges we continue to address. So I've been working with Powys Teaching Health Board for around 4.5 years now. Before joining the organisation, I worked for Powys County Council and Freedom Leisure, which gave me a strong foundation in asset management, property information and public sector service delivery. Within Estates, I'm part of the capital team, where I support the delivery of capital projects across the estate by providing building information, technical drawings and surveying services. Alongside my primary role, I also act as Deputy Asbestos Manager, supporting compliance and risk management activities across the organisation, and I'm also a member of Chat to Change, which has given me the opportunity to contribute to staff wellbeing and engagement initiatives beyond my core responsibilities. So a significant part of my role involves maintaining accurate as-built drawings for all of our properties. These drawings provide a reliable record of our buildings and are used to support maintenance, capital projects and compliance activities along with future planning. I work closely with the capital project managers to develop and update our project drawings from conception through to completion, and I also work alongside our estates and property teams to ensure items such as maintenance plans, leased area drawings are up to date and accurate as possible. Having accurate building information is essential. It helps colleagues make informed decisions, reduces risk during construction and maintenance activities, and ensures we have a dependable record of our estate. Many of these drawings support projects that may never be visible to patients directly, but they play an important role in ensuring our environment remains safe, functional, and fit for purpose. For example, our fire safety projects that have recently been completed at Brecon and Machynlleth and are now on schedule and programme for Llanidloes this year. So over the last few years, we've increasingly adopted digital surveying technologies, including Matterport and the Leica Black2Go scanning system. These tools allow us to capture highly accurate three-dimensional information about our buildings and spaces much more efficiently than traditional survey methods. The benefits include improved accuracy, quicker access to information, better project planning, and a reduced need for repeat site visits and officer travel time across our estate, which is obviously beneficial given the geographical challenges we face in Powys. These technologies are helping us build a more detailed digital understanding of our estate to support more informed decision makings across a range of projects. So, my role also includes supporting the Health Board's asbestos management activities as Deputy Asbestos Manager. Working with the Asbestos Manager, I help coordinate surveys, provide technical information, and support to colleagues who require asbestos-related advice. A key part of this work is ensuring accurate information is available before maintenance or construction activities take place. This contributes directly to contractor safety and staff safety, supporting compliance within the Health Board's legal requirements, and helps the organisation manage risk appropriately. I'm also involved in reviewing policies and procedures to ensure our systems remain effective, practical, and aligned with current requirements. So outside of my formal role, I'm also proud to be involved with Chat to Change. The group focuses on improving staff well-being, communication, and engagement across the organisation. Some of the projects I have supported include creating site information boards that are aimed at displaying useful information to staff who may be unfamiliar to a site they're visiting. These display who the site's current Chat to Change representatives are, along with promoting well-being locations and raising awareness of the Chat to Change initiative itself. This involvement has given me the opportunity to work with colleagues from different departments and contribute to creating a positive working environment. For me, it demonstrates that every member of staff has the opportunity to influence change within the organisation, regardless of their job title or area of work. So as the estate's function continues to evolve, there are significant opportunities to build on digital capabilities and specialist expertise that are already being developed. Continued professional development remains important, and in previous years I have completed ILM5 and I'm looking to continue that development through more technical, job-related training that would benefit both myself and the wider estates team and organisation. Technology is also transforming how we manage our estate. Tools such as the LiDAR laser scanning, Matterport, and digital twins technology create opportunities to improve asset information, support planning processes, and enhance operational efficiency. Expanding into other digitally driven areas such as GIS mapping would further complement what we're already starting to build. So one of the biggest challenges we have is keeping pace with this rapidly evolving technology whilst maintaining my business as usual responsibilities. However, the ability to harness these innovations to improve estate information, support decision making, and deliver tangible benefits for the organisation makes it a particularly rewarding aspect of the role. So in summary, my role brings together estate information management, digital innovation, and compliance activities to support safe, efficient, and well-informed management of the Health Board's estate, While much of this work happens behind the scenes, it plays an important part in supporting safe buildings, effective projects and informed decision making across the Health Board. So I want to say thank you for your time today and having me here, and I'd be happy to answer any questions.
Tom, thank you so much. There's lots we could say in terms of that very impressive and informative presentation. But I'll go initially to our Acting Chief Exec, Pete, for any initial comments. And then colleagues, if anyone does have a comment or a question that you'd like to pose, please do indicate. Pete, please.
Yeah, thank you, Carl. Good morning, everyone. Pete Hopgood, Acting Chief Exec. Just to echo your comments, Carl, Tom, thank you for that. Really insightful, really interesting. And I just wanted to thank you and the whole estates team for the hard work that you all do for the Health Board. So thank you very much.
No worries, thank you.
Yeah, let's go to some colleagues. We'll go to several colleagues, beginning with Jennifer Owen-Adams. Thank you, Jen.
Diolch, Carl. Thank you. Tom, thank you very much. Jennifer Owen-Adams, independent member. Tom, I'm also chair of the People and Culture Committee. Tom, and I was really interested to hear about your Chat to Change, the Chat to Change section that you talked about. Could you just share a little bit more about what's behind that and how you found it and how people who have participated in that have found it too?
Yeah.
Sorry. If you we'll just hold the question, Tom, if we may, and let's go to some other colleagues, and then we'll come back to you if that's okay. Let's go to Ian.
Thanks, Chair, and I'm Ian Thomas, independent member. Tom, again, thanks. Just to reiterate what other people have said, thanks for the presentation. It's informative. I think it's really important. I think, given this is, we're public facing on this, that the population know how things are handled on property, because at the end of the day, it's where people go, and I think that's really important. So, appreciate the size of your portfolio. Jen has pitched a question around more information about Chat to Change. Mine's a little bit more technical, if I may, and it's concerning the way that we are going to do GIS in the future. And I've dealt with those tools myself, so I know how complex they can be. Are you going to be able to have a reference group on GIS across other NHS bodies in Wales? Because I'm just conscious of the fact that GIS information can be quite, it's quite detailed in terms of how we define methodologies. Because I think, again, for people at Powys, that's going to be really important to know we're using the tech correctly. The same would go for AI, but GIS specifically. Okay.
Okay.
Thanks, Ian. Let's go to Paul.
Hi, good morning, Tom, and again, great presentation, and thank you. Mine isn't a question, it's a comment with my clinical hat on, just to acknowledge and recognise the work that Tom and estates do to keep our patients safe and to keep the environment running and safe. I think that there's a lot of unsung heroes behind the scenes that do these jobs, and certainly estates is one of them. And my experience of working with them since I've come into the Health Board, they've been responsive and been quick, and they've dug us out of some holes. So thank you very much to you and your team, Tom.
And finally to Kathy. Thank you, Paul.
Morning, Tom. Kathy Poynton, independent board member. This isn't a question, it is a comment. Tom, you are hiding your light under a bushel. I sit with you on Chat to Change, and you are not telling us half of what you've done and what you've got in the pipeline. I would like to say thank you. You've inspired a lot of us on Chat to Change of what we could take forward, along with the Estates Department. You're doing such a good job.
Oh, thank you. Thank you, Kathy.
Thanks, Kathy. So, Tom, let's come back to those briefly, if we may. Two specific questions. Your experience of Chat to Change and GIS and the Wales-wide reference group. Just a couple of comments, please.
Okay, I'll go for GIS first, if that's all right. So we're in quite early stages with GIS as a whole, sort of starting to develop more estates-related internal usage at the moment, but that's a very good point to sort of branch out wider to see how we can apply it across across everywhere. So yeah, no, definitely something to look at.
And chapter change.
So yeah, chapter change. It's been a really, really good, useful group to be involved in, to hear different stories and sort of different ideas coming from all ranges of the health board and at all levels. And sort of the information boards. So I was brought in by our associate director Wayne into the group, who also sort of leads along with others in other individuals involved with it, to sort of help with the drawing side and sort of move it forward. So we've all come together and sort of tried to develop useful information for staff that they might find if they're coming to a site that they've never been to before, and sort of looking to develop that more into where their well-being areas are and other useful locations around. Yes. Sorry, does that help?
That's really helpful. Thank you, Tom.
Thank you.
And on behalf of us all, just to reiterate the thanks, it has been my pleasure during my time in this role to spend some time with you and your team, and to see some of your achievements, and indeed to on occasions to present you with awards. And so it's really, really good to have you with us today. And please do take away with you our heartfelt appreciation, and please convey that to your colleagues. Thank you.
Brilliant. Thank you. Thank you, Carl. Thank you.
So we go to our patient experience story. I will ask Paul to introduce this, but it's important for me to say initially that as always, or rather as often happens with patient stories, they are about real people and real experiences, and sometimes these can be quite sad, quite upsetting. And our patient story today does involve the death of a loved one and bereavement, and focuses on the care that this individual and her loved ones had whilst visiting Powys. So if that's going to be particularly upsetting for anyone, then please do feel free to step away from our meeting for the next 10 minutes or so and then rejoin us. That's absolutely fine. But Paul, please come in.
Hi, thank you, Carl. And just to re-emphasise, it is a sad story, and there is some elements of distress in it, but equally there's the focus of the story, believe it or not, isn't necessarily around this lady and her husband, who were travelling through Macklinst on their way to Tamworth when her husband, who was on a terminal ill pathway, suddenly became extremely unwell and went into Macklinst Hospital. And the care they received as they arrived there was exceptional, as you will hear. But equally, what was inspirational within the story was how, as this young lady had to care for her husband and go on an onward journey to hospital with her husband, they had a cat in the car, and it was about what was going to happen to the cat. So the story is entitled Billy the Cat. I'll say no more than that, and I'll let her tell her story.
So in July 2025, Terry was diagnosed with liver cancer. He was given a very poor prognosis with just months to live. He was determined that before he died, he would do all of his outstanding DIY jobs. That's both at home in Tamworth and here at our holiday home in Macuncle. On the day Terry became poorly, he'd taken out the shower cubicle. We'd had a lovely Chinese meal on the night time, and everything was just as normal. He'd been really fortunate that he didn't feel poorly all the time since he'd had the diagnosis. But when we went to bed that night, he was violently sick and started to complain of stomach pains. Because he'd been up all night vomiting, I decided the next morning that I needed to get him home so we could see his GP. We got up and we were travelling back from Wales back to Tamworth. We'd been in the car about 40 minutes, 45 minutes, and I happened to look over at him and I could see that he had deteriorated drastically. Pulled over the car to the side of the road just as the GP practice rang me. They were ringing to tell me that they'd got an appointment for Terry for Friday, and I explained to them that I actually didn't think he was going to make the appointment because, you know, he deteriorated significantly in the car. And I was starting to think, I'm going to be driving around with a dead body in the car. I knew it was, like, you know, quite serious. At that point, a police officer pulled up behind me. I pulled onto the dual carriageway on the bypass in Newtown. A police officer's come up to the window and said, you know, is there a problem, madam? Why are you parked here? And I pointed to my husband and said, like, you know, my husband's extremely poorly. I'm just on the phone to GP practice. They're trying to find me the directions for the nearest hospital. He gave me verbal directions. The GP practice, he then went. The GP practice gave me the postcode. And I was literally on the bypass, so I realised it was something like 0.something miles to the hospital. So I knew I hadn't got far to go. So I got to the hospital in Newtown, and my heart sank when I seen the sign that said no A&E. Because I thought, when I go in, I'm going to have quite a frosty reception. You know, they're going to say, you know, no point you bringing him here. You can see that quite clearly we're not set up to deal with this. But regardless, I pulled into the disabled parking space and I went into the receptionist. She could see the state I was in. And she just literally went into autopilot. She took my name, she took my husband's name, his date of birth, you know, all those necessary details. Kathy, the senior nurse, came out to me. She assessed Terry in the car and could see how poorly he was. At this point, I believe that the lady on reception had dialed 999. Kathy and I couldn't get my husband out of the car, so Kathy called the assistance of two staff from the physio department, and they helped get Terry out of the car and into a wheelchair. And they were able to take him into a little clinic room in the hospital. And Kathy was able to continue to check on him and everything else. By this point, we could hear the sirens coming for the ambulance. So Kathy decided to leave Terry where he was on the chair rather than trying to make him more comfortable. From what Kathy was saying to me, she affirmed for me that Terry was dying. You know, I knew that deep down, but she affirmed that for me. The ambulance came and they assessed Terry, and they concluded as well that Terry needed to be taken to Shrewsbury where he could be made comfortable. We're saying at this point that I needed to travel with Terry in the ambulance because they weren't even sure that Terry would make it to Shrewsbury. Whilst I was thinking about that, it dawned on me that I couldn't go with Terry in the ambulance because I've got the cat in the car. The cat comes with us on holiday. And so Kathy, the senior nurse, and the ambulance people went out and had a private word. They then came back in and Kathy said, I want you to listen to what I've got to say. You need to go with Terry in the ambulance. She said, you know, they said that they weren't sure that he would make the actual journey to Shrewsbury. I needed to be with him. And I was blown away when Kathy suggested that she would provide foster care for Billy the cat whilst I accompanied Terry in the ambulance. She assured me that she'd got cats of her own and that she would look after him well, and that it didn't matter how long it took for Terry to pass. You know, she would look after the cat until I was able to make it back. So I got Billy the cat out of the car and gave him to Kathy, and then I was able to travel with Terry in the ambulance to Shrewsbury. He did make the journey, and we didn't have to pull into the side of the road. The ambulance staff had said to me that should Terry deteriorate and pass on the journey, that they would pull to the side of the road and, you know, make sure that he was comfortable and we've got dignity in that. When we got to the hospital, the ambulance people again assured me that should there not be a bed available for Terry, that he wouldn't be on a trolley in the corridor. And it was only after about 10-minute wait or something like that that a bed was confirmed in resus. And I stayed with Terry at Shrewsbury Hospital all of Thursday afternoon. and until Friday when Terry passed away, sort of 9 o'clock, 9:30 in the morning on Friday morning. All of the time whilst I was at Shrewsbury with Terry, Kathy messaged me. She sent me photographs of the cat. She told me when he'd used his litter tray, that he'd eaten his breakfast. And she sent me videos of him. She told me that her husband had been up and spent some time with him in the room as well with him. And to have that comfort and not having to worry about the cat whilst I was with Terry at the hospital was, well, I can't describe it, because had Kathy not done that, I don't know what I'd have done. You know, Kathy was an absolute angel, and to do what she did was above and beyond the call of duty. You know, my whole experience from when I pulled up outside that little hospital, from the lovely lady on reception who just went into just sort it out mode, she was just absolutely brilliant, to the student nurse who consoled me while I was in absolute bits, and to Kathy for having, you know, how on earth she thought about that, I just don't know, because I don't think that would have been a solution that I would have thought of. It just made such a difference. You know, it meant that I could spend that time with Terry without having to worry. Obviously, I called back on the Friday morning after Terry had died. I got a taxi back from Shrewsbury back to the hospital in Newtown, and the staff were lovely, and then waited for the cat. And then I learned that some staff in facilities had fed Billy tins of corned beef, so he didn't go hungry before Kathy could get him home. And it just seemed that, like, everybody just pulled together to make what was a terrible situation into something that, you know, everything worked out for the best in the end, as strange as that might sound.
Thank you. Again, I'll invite Pete to offer any initial reflection. We don't have a lot of time, but if any colleagues do want to make a very brief observation or comment, then please do indicate. Pete.
Yeah, thank you, Carl. So what an absolutely moving story that has just been shared with us, and it just emphasises the fantastic staff that we have in the health board, and those people who went well above and beyond to support in that situation. I just want to recognise that and thank them. And yeah, our staff are fantastic. Thank you.
Absolutely, Pete. Thank you. And Rhiannon.
Diolch yn fawr. Yes, obviously a very distressing time for Christine and Terry, and our staff absolutely amazing in terms of how they responded at every point of that scenario. I suppose the only thing I was left curious about was, we obviously have a lot of people potentially with second homes in the county, a lot of people who visit for holidays, etc. And I just wondered how we go about trying to ensure that communication about you know, arrangements should they become unwell, how that's handled, I suppose. Is that just through our general comms? Is there any other work that we've been doing to try and ensure that people know where to go, what to do in moments of health concern?
Thanks, Rhiannon. Pete, do you or one of your colleagues want to come in very briefly, if you would, please, in response to Rhiannon's question?
Yeah, thank you, Rhiannon. I think it will be covered in our general communication around access to services, what's available. We've got information on our website, via social media, so it will be through that medium that we do that.
And Paul, please.
I would agree and support what Pete said. There's a lot of cons. People see a hospital sign and they head in that direction. And I think what's really comforting to know that when they do, they're not turned away. We try and support them the best we can while we seek further assistance through the ambulance service, etc. So, and no matter how much communication you do in the world, and I'm sure you know that yourself from your own experience, Rhiannon, as a director of nursing in the past, people will always follow a hospital sign because they'll feel it's better than nothing, and most often than not, they're right.
Thank you. Thanks, Rhiannon. So again, a big thank you to all of us, to Christine for sharing her story, and that will certainly be one of the sources of information and influence in our minds as we go through the rest of this meeting, and indeed as we fulfill our responsibilities more generally. So a big thank you for those. Under item 1.5 of our agenda, we have not received any questions from the public for our consideration at this meeting, and therefore there is no business under that agenda item, which takes us to item 1.6, and initially to my update report as chair. I'll take the report as read. I'm happy to respond to any question or enter into discussion about any aspect of the report, if anyone would like to contribute. No, therefore, thank you for that. In which case, we go to our Vice Chair, Rhiannon's report. Again, we take as read. Any additional comments from you, Rhiannon?
Not really, Carl. I think it just sort of reinforces in terms of the story we've just had and my experience of meeting staff when I've been out and about over the last couple of months. But I think also just to say, we look forward to working on the quality management system in terms of oversight in patient experience, quality and safety committee. So that's referenced in the report as well. Thank you.
Thank you. Colleagues, would anyone like to come in with a question or comment in response to the Vice Chair's report? Please do, Chris.
Thank you, Chair. Councillor Chris Walsh, Independent Member, Local Authority. Thank you for your report, Rhiannon. I think it's really helpful. I'm glad you're settling in and finding your way around as well. My question is in relation to the RIF funding, which you mentioned, particularly around some of the uncertainty around that. And I just wondered how that was being managed and what was the process, because that crosses over not only within health services, but also with the local authority. And I just wonder how that is being managed so that we can assure the public around those service provisions that funding then supports. Thank you.
Well, Carl might want to come in as chair of the Regional Partnership Board, but just to say from my perspective that both the Health Board and the Council have been working very, very closely together with Parvo and other representatives, both patient representatives or people representatives and third sector. And I think obviously there is uncertainty from the perspective of government hasn't yet made announcements around arrangements, and there is some consultation, survey work going on at the moment with a view potentially to a more formal consultation in terms of regional partnership boards more broadly. But I think just to say that the actual looking closely at initiatives and projects which have an inject of money to get them going obviously needs to be constantly evaluated in any event. So I don't know if Carl, you want to add anything further.
Just to support that, I think, Rhiannon, Chris, I can give you my assurance as chair of the RPB that a robust process and procedure, exactly as Rhiannon says, is in place. It's been in place now for some time. It's a collaborative process where the council the Health Board, third sector and other partners around the RPB table are working together to manage the fact that the current RIF funding is due to come to an end at the end of this financial year. We always knew that. It was never intended to continue beyond this. And exactly as Rhiannon says, we are awaiting announcements from the new Welsh Government as to what they may put in place after this financial year, but that yet is unknown. So yes, there are those collaborative processes in place, Chris.
Okay, thank you.
Thank you. So thank you, Rhiannon. We move now to our Chief Executive, Pete's report. Again, taken as read. Do you have any additional or introductory comments, Pete?
Yeah, thank you, Carl. So yeah, just wanted to make a couple of points, and then I think we can pick up on the rural response model as raised earlier. So first of all, I wanted to give a big thank you and huge recognition for our staff response to the recent extreme heat situation that we all found ourselves in. The commitment, the resilience, the innovation of our staff just highlights again how fantastic they are, but also our need to recognise that we need to be ready and to strengthen our climate change preparedness. So that was the main thing I wanted to recognise. Also to note that we've got our new staff recognition framework. Again, we referenced this a little earlier, and that's really important that we recognise our staff, we improve their well-being, and we support that positive organisational culture. So if we move on to the item as raised in terms of the rural response model, if I reference the paper, I think the key points to note from the joint committee are that an 8-week engagement programme will be undertaken during the summer-autumn of 26. The engagement will be coordinated by the JCC, the Joint Commissioning Committee, and delivered where possible through existing Health Board and WAST engagement arrangements. Llais will support through their regional mechanisms, and the activity will include a bilingual briefing document and online questionnaire. And then on the back of this engagement and responses, that will inform and development of a rural ambulance improvement proposal. So that is the latest position. That detail is included in the report. And perhaps now we can open that part up to any questions, Carl, and have a wider discussion, and then pick up on any other questions from the Chief Exec report. Thank you.
Thanks, Pete. So exactly as Pete has suggested, let's take questions and comments specifically around the EMERTS and Rec 4 update, and linked, of course, to Helen's comment earlier as to whether or not we close this on our action log. Let's go firstly to Robert.
I'm quite happy, Chair, for Mick to come in initially because it was his question.
Mick?
Sorry, at the risk of playing tennis, I'm quite happy to defer to Robert because I suspect we're going to raise the same issue, and he raised it last time. So, Robert, please go. All
right, thank you. Yeah, Robert is a very general independent member. Thanks for the report, Pete. Yes, recommendation 4. The minutes from this board from our last meeting state that the JCC has agreed that the work should continue at pace. And I think the question really is, how fast is fast? Because it's never felt like as if it was fast. There's something very odd about the way that this proposal, which many people thought was already agreed in principle, has been processed and dealt with. After all, we're talking about, I think we're talking about a 4-wheel vehicle, staffed by WAST. And I know that other IMs will keep an eye on this, that Powys Health Board's only one voice on the JCC, and Pete and Executive will keep the pressure on. But if we're in the position that we are in now in 6 months' time, it really will not reflect very well on the NHS when relatively modest projects like this compared to so many larger ones are taking so long. I will leave it there, Chair, and perhaps invite Mick if he has any additional comments to make. Thank you.
Thanks, Mick. Please, we'll come to you and then we'll go to Simon.
Thanks, Joe. It was essentially the same point, so I won't repeat it. About the pace of progress and the resolve almost to get to this, and it was just on the process issue, really. The question was, can we close this and take it off the board's agenda? I don't think that's appropriate unless there is, some form of mechanism which will provide that reassurance that we are continuing to monitor this, that there is an active interest, and that the interests of our community is being robustly pursued, given that we are a kind of minor voice in quite a large picture. So agree entirely with Robert. Mine was about the process, really, and concerns about taking it off our radar without some form of monitoring arrangements behind it.
Thank you. Simon, please.
Thank you, Carl. Simon Wright, independent member. Just to agree with what both Robert and Mick have said, I had a bit more of a specific query around: are we content that the engagement via an online questionnaire is going to be sufficient and really reach all those who may have important views to feedback on this consultation process? It struck me as a bit limited. So just any comments on that would be helpful. Thank you.
Thank you. And Katie, do you have something you'd like to comment?
It's just an observation, really, Carl. Thank you. Given that this will obviously affect Powys residents, as will the consultation, the Better Together consultation, and there's likely to be an overlap. So it's just an observation that during that period in time, there are going to be two significant consultations for Powys residents.
Thank you, Katie. I can see that Nicola also wants to come in. Please do, Nick.
Yes, thank you. I would agree it wouldn't be wise at this stage to take it off the action log. I think as a board we need to keep really close eyes on it, and at the moment that's the way that we're doing that. I think in this space in the JCC we actually bat above our weight. It is well recognised that this affects our population as well as parts of Hywel and Betsy particularly, so we always weigh in. We always present the views of the population as we know them through the extensive engagement that was previously done around the EMERTS model, but also all the engagement work that we do, and that is listened to because it is well known that obviously it's our population as well as others that it reflects. I think on the engagement methodology, Simon, the feedback from our engagement lead is that there's further meetings being arranged to discuss that, so that we will be involved in shaping that. So I think what we've got here is the initial proposal. So I think it'd be a questionnaire at least, but obviously we'll influence that as well. In discussion with Kate, who's not here today, so obviously I went to JCC last week, their formal meeting on behalf of the Health Board, and made sure that our views and the population's views were represented, and had tested this with Kate for the clinical view prior to that. I think we understand concerns of the board about timelines, but actually we think this process will get closer to having a solution which we think may suit our population better. And we also, as we know in the performance space and the performance report, always note that response times in Powys are the worst in Wales, and we very clearly represented that we would want that to be taken into account in terms of designing this solution. So I think clinically we feel the process as laid out now is probably more suitable than the solution that was suggested in the original recommendation 4, but we continue to man-mark it both from a corporate point of view and a clinical point of view. Thank you.
Thanks, Nicola. I know Helen wants to contribute, and you please, Helen. Just an observation from me. I think what I'm hearing is that there is a view within the board that we need to keep sighted on this, and we shouldn't let it disappear from our citedness. I'm just wondering, and Helen, you will want to comment on this, whether the action log is the right place for that. It's beginning to feel to me a little bit more like an escalated matter rather than a specific action. But I'll certainly defer to you as to how we might manage that in governance terms. I don't know whether that's through a committee and therefore an escalated matter, or do we, so please do come in with any advice you have. And of course, it might be that we don't want to precipitate a set of words or whatever today that may not be sufficiently thought through. It may be that we want to think about this and come back to it, but nonetheless hold on to the point that we need to remain cited on this matter. Helen, please.
Yeah, thank you very much, Carl. So the mechanisms we currently have in place to ensure that the board remain cited and have the opportunity to contribute to this. So I think this item has appeared in every chief executive report, certainly for the last 18 months or so. So it is constantly on the agenda through that mechanism. We also have in the consent agenda the report that comes from the JCC and our other joint committees as well. So copies of the highlight report come through there. I informed you as a board last time that colleagues from the Joint Commissioning Committee were due to join board development in August. At the request of the JCC, that has now moved to October. So we also have the opportunity to discuss the matter and other matters directly with the new Joint Commissioner and the chair of the JCC in October as well. So Carl, coming back to your point, I'm not sure the action log is the right place. I think bearing in mind the conversation we had earlier about the action log, we run the risk of it just carrying a series of updates in truth, and we're trying to not promote that that behaviour, as it were, or that action. So I'm wondering whether or not, Carl, you and I just not necessarily on the action log, but take an action just to consider the best route. In my view, there is direct citedness through both the Joint Commissioning Committee report and the Chief Executive report. And of course, at any time, an agenda can be added onto the board meeting itself when there is something for the board to, kind of formally debate. And we can consider whether or not it needs to be an escalated item as well. It doesn't necessarily need to be through a committee. So in short, I'm not sure the action log is the right place. I think we have other mechanisms that are more appropriate.
Thank you, Helen. And I think your point about the escalated matter not necessarily needing to come through a committee is a helpful one. Let me just turn to Mick, Simon and Robert particularly. Are you content, colleagues, that Helen and I look at this and come back to you with a proposed way of maintaining our citedness on this matter? Does anybody want to comment? Mick, please.
I'm very happy for you and Helen to resolve it. The only comment I would make is that this is, quite clearly a matter of public concern. We saw the feedback from the public to the original consultation, and the board is the place where the board, where the board is operating in public. So I think it needs to remain visible to the public. But I agree with Helen that repeatedly putting it onto the action log is not the right place.
Thank you.
I also agree. Yeah, agree with me.
Robert?
Yes, I agree.
Okay, thank you. So Helen and I will look at that and give it some more detailed thought, and we'll confirm with colleagues what our suggestion is as to how we maintain that citedness. Does anyone want to comment on or ask a question about any other aspect of Pete's report? Ronnie, please.
Thank you, Carl. Pete, can I say, first of all, this is a very good report, and I was impressed by the thoroughness of it. I have two questions, which I suspect are for Stuart. On page 4, there's reference to the seasonal respiratory vaccination programme having concluded for RSV, COVID and flu, and I'd be grateful to know how successful that's been in terms of the percentages achieved. And if we don't know that yet, when is it likely that that information will be available? My second point is allied to that in a way. There's been very compelling medical evidence about the success of the HPV vaccine in preventing cervical cancer. And when we look at papers further on in the board agenda, we will see that we are about 10 to 15% adrift in terms of the percentages achieved for that. I know that there is a catch-up program in place, but I'd just be grateful for assurance that the catch-up program is working effectively in practice, given the importance of this vaccine in preventing cervical cancer. Thank you.
Thank you, Ronnie, for the questions. I think if it's okay, I'll ask Stuart to come in and just to give an update in those areas. Thank you, Stuart.
Yeah, thank you, Pete. So Stuart Bourne, I'm deputising for our Director of Public Health at today's board meeting, who's on leave. Just to pick up, Ronnie, your question about vaccination programmes and uptake for the various programmes that some are still running and some have recently finished. I've got some headlines from a few, Ronnie, that I can just give you verbally now. Obviously, some of the programmes sort of flu COVID, we do break it down by different cohorts. So I haven't got the full detail by the different eligible cohorts, but I can say for the spring COVID campaign, which ended actually recently, 30th of June was the end of the spring COVID booster campaign. Our overall uptake was 54% for all eligible groups, of which I think off the top of my head there are about 4 different eligible groups as part of the spring campaign. That was lower than target where we would like to get to in terms of uptake. I should say that at the start, but relative to other health boards, we did have the highest uptake as a health board in Wales for the spring COVID campaign. So as I said, we got 54% at the end of June, and it's about 51%, I think, for Wales as a whole. So we're slightly better than the Wales average, but we recognise we would always want to go further with our uptake against target. RSV program is currently running. There is some uptake data for RSV just in the integrated quality performance assurance report just a little bit later down the agenda, but just to pick the top lines from that report for RSV as at the end of May, so a couple of months ago our uptake was 55% for all 75-year-olds as they turn 75, and again that's slightly better than the Wales average, which is about 10% lower at the moment, about 45%, and obviously below 70% target. So again, we recognise we're below target, but relatively strong performance for 75-year-olds for RSV vaccine as at the end of May. Probably the other one I would just pick up, Ronnie, is the meningitis B catch-up program that is one that some people will be aware of following the Kent and Canterbury meningitis B outbreak a few months ago, quite high profile. Across the UK, there's a meningitis B catch-up running over the summer period up until the beginning of September, and that's 2 cohorts, 17 to 18-year-olds, so 6 formers effectively, and then anybody up to 25 years of age who's attending higher or residential further education for the first time this autumn. That campaign started mid-July, so it's relatively recently started, particularly for 17 to 18-year-olds. We've got about 1,600 in Powys that we're working to try and vaccinate over the summer, and we're currently at about 28% uptake for 17 to 18-year-olds as at the end of July for that programme. Again, that's the highest health board in Wales currently, and that's a 2-stage program, so we vaccinate twice for that with about 28-day, effectively a month space. So we'll be offering second appointments for both of those 2 cohorts from about mid-August. So just some top lines, and Ronnie, I've got some more detailed breakdown figures I can send offline if that's helpful to give you a bit more narrative around that side. Just on HP vaccination, yep, you're absolutely right. Some very strong evidence came out relatively recently about the value of that programme in terms of prevention of cervical cancer. It's delivered predominantly through our school nursing service in Powys, so it's part of that element of our vaccination programme. And you're absolutely right. The uptake for that is okay, but we would like to go further with that. We do a variety of interventions with schools through school nurses. We do monitor uptake by school, and we do go back in and do catch-ups around that programme and others in schools on a school basis. But it is an area of vaccination that is really valuable and really effective, but we recognise it's one of many vaccination programs through schools and younger age groups we need to continuously focus on.
Thank you, Stuart. Ronnie, do you want to comment further or respond in any way?
No, thank you. I'm content.
Thank you. In which case, let's go to Rhiannon.
Thank you, and thanks, Stuart, because I was going to ask you about Men B as well, but I have got another query. So I'm just curious to understand a bit about the rationale behind why just a single key question has been developed for the consultation around rural ambulance response. I'm just wondering if you have any context for that, because it just seems an unusual approach just to have one single question, and I'm wondering how effective it's thought that will be in terms of really getting an understanding of communities' views or the population's views. I understand that Clyce helped to write it, so I don't know if Katie has that background, but it just would be useful to understand the rationale for that.
Pete, do you want to bring somebody in, or?
So I think we're going back to the rural response model item that we just previously discussed. I think there's a little bit of a following the JCC lead in terms of engagement. As they've referenced, they have involved Clyce. They will be a meeting with ourselves and other health boards that it relates to take that forward. So as that develops, we keep it as a regular update in the arena, subject to the comments that Helen and Carl made earlier. So I don't think there's anything more to add to that, but we can bring more information in terms of that engagement as it progresses.
Yeah, okay, Pete. Understood. I suppose it just, for me, I just think it's very difficult for people to be able to give views based on one question. So that's where I'm coming from on it. Thanks.
Thanks, Rhiannon. Let's go to Chris, please.
Thank you, Chair. This is just picking up on the meningitis B vaccination, which obviously I welcome, and it's had quite a lot of attention. Obviously, the success of that programme is dependent on the second dose being achieved. Can I just have the assurance, when someone attends for the first appointment, do we give them then the date of the second appointment there, or do they have to rebook it separately as a part of that? It's just to making sure that the 28% of that target group that you're looking for is maintained, and is that above your expectation at this stage? It sounds quite promising that we've only just started that programme with that high percentage.
Shall we go back to Stuart, Pete, for that?
Yes, please.
Please come in, Stuart.
Yeah, thank you, Chair. Happy to come back on that. So in relation to the first question about the invite system, no, the person that's vaccinated doesn't have to effectively opt in for that second dose. It may not happen at the point of appointment, but they will get an invite from our vaccination service for that second appointment. So it's an automatic process. They won't have to do anything themselves, that they will get that offer through the health board directly. In terms of the second point, it's a tricky one to comment too much on uptake because it's obviously a new programme. It's not one we've delivered before for this age group, although we do vaccinate against meningitis B at earlier age groups. So it's difficult to say, but we're relatively happy in terms of our relative performance compared to other health boards in Wales, but we'll obviously continue to monitor that uptake week by week and just to keep a close eye on the trend in terms of uptake as we go forward, particularly for both cohorts, because we're also conscious of the older age cohort as well, as we go forward over the course of the summer.
Thank you very much. I can't see that anyone else wants to contribute in response to the Chief Executive's report. And so do you have any concluding comments, Pete?
No, thank you, Carl.
Okay, well, thank you very much for a very helpful and clearly very thought-provoking and stimulating report. It brings us to item 1.7 on our agenda. I mentioned earlier the very detailed heavy lifting work that our subcommittees do in terms of the scrutiny of our performance in various ways. And as we always have on our agenda, we consider now the assurance reports from those committees and from the chairs of those committees. And so we turn firstly to Steve Elliott, the chair of our Audit, Risk and Assurance Committee, in relation to two reports from two meetings. Thanks, Steve.
Thank you, Carl. Yes, Steve Elliott, independent member. As you just said, there are two reports. The first report relates to our meeting early in May, which I gave a verbal update at our last board meeting, so I wasn't planning to cover that one. The second paper relates to the meeting that we held earlier this month. So I'll take the paper as read, but just highlight a few points from it. We took assurance on progress of the internal audit plan. At the meeting, that's the stage of the meeting, there were only 3 reports that are at draft or final stage. But there are a further 8 reports that are in the planning stage by internal audit. So we did take assurance at this point that the plan should be delivered in full by the year end. But as in previous years, the review of the reports is likely to be backloaded towards the middle and end of this financial year. We also took assurance, as we have done on previous occasions, that there are appropriate systems in place to track the organisation's responses to findings from both internal and external audit reports. And finally, just to note that we did note progress against the counter-fraud work plan for the year, but noted that there are capacity challenges which are impacting on the pace of delivery of the plan. Happy to take any questions. Thank you, Joe.
Thanks, Steve. Colleagues, please do indicate if you have any questions or comments in response to the ARAC reports. So thank you, Steve, and thanks to you and committee colleagues for all your work, which means that we turn our attention to the Charitable Funds Committee and its chair, Ian Thomas. Thank you, Ian. I think
Ian, with apologies, Ian's had to just temporarily leave the meeting, sorry. So I wonder if we could take that report as read. I was in the meeting, as I think you were as well, so I'm sure between us we could field any questions.
Yeah, thank you, Helen. I had noted that Ian's had to dip out of the meeting temporarily, so yeah, apologies for just missing that there. So, colleagues, we'll take the report as read. As Helen said, there are those of us that were in the meeting, and if there are any questions or comments, then we will respond to those. Does anybody want to come in? No, therefore we receive that report, and we go now to our Finance and Performance Committee reports and to its chair, Ronnie Alexander. Thank you, Ronnie.
Thank you, Chair. There are 2 reports which are referenced in the papers. The first one of which is on the 14th of May, 2006. There were no escalation items specifically referenced, but there are a number of items that are referenced for assurance, which are covered in pages 2 to 4. There's nothing that I need to say about that in addition, but happy to take any questions or observations. The second meeting was on the 25th of June 2026. There is one escalation item there, which is, I'm just searching for that at the moment, thank you, which is our organizational escalation status, presentation, finance and performance monitoring. That's a standard item which we consider in escalation. Then there are a number of items which are referenced under assurance. So I'm taking the remainder of that report as read, but happy to answer any questions or observations.
Thank you, Ronnie. Once again, colleagues, does anybody want to ask a question, make a comment, enter into discussion about any aspect of the F&P reports? There are none. So and a big thank you to you, Ronnie, and to your F&P colleagues for that work, which takes us to our People and Culture Committee and its chair, Jennifer. Thanks, Jen.
Hello, good morning. Thank you. Yes, Jennifer Owen Adams here, so Chair of the People and Culture Committee. We met on the 11th of June. As you can see from the report to board, there are no issues to escalate to or advise the board of. Headline summary of our meeting is our heavy lifting, of course, is against people and culture. All the issues there. We considered Deborah Wood-Lawson, she's obviously our Exec Director for People, Culture, Transformation. We took Deb's summary report on the workforce elements against our in our integrated plan, and also Deb updated us on a number of regional and national issues which are pertinent to workforce issues back in our health board. We looked at our very detailed report of the workforce performance report. In that report, we consider and analyse a range of workforce metrics, whether it be headcount, vacancy rates, retention, turnover, etc., a whole range of metrics. And we look at that data where it is up to date, but also more importantly, looking at the trends. And as a result of that, we're able to draw conclusions and focus on what the issues we want to look at next time. We then took a deep dive into two of our people and culture related themes in our integrated plan. This time we looked at staff health and well-being and workforce sustainability and transformation. And again, we noted and took assurance against a number of measures and data on the ongoing work in both of those areas in terms of our work and continuously improving our work in those areas. We took assurance against that. There's one particular item that I'd like to draw the board's attention to, which is something that we looked at for the first time. Deborah introduced us to the new financial grip and control assessment tool, which is a tool which has been devised by NHS Wales, which we're using along with all the other health boards across Wales to assess the extent to which we have sufficient financial and workforce controls, that those controls are operating effectively. We were assured from Deb's paper that that indeed is the case. That there is good and robust governance on these matters, controls are in place, and we have active insight and a very targeted grip in high risk areas. So we will continue to monitor our performance against the criteria in that tool and continue to receive reports on our performance against that tool. Our next meeting is on the 8th of September. Look forward to that and very happy to take any questions. Thank you.
Thank you, Jen. Colleagues, please do come in if you have any questions or comments in response to the People and Culture Committee report. No, so and a big thank you to you, Jen, and to your committee colleagues for that work. That takes us to our PPPH committee, which is Planning, Partnerships and Public Health Committee. Its chair, Dr. Robert Lewis. Thank you, Robert.
Thank you. Strategic change, especially relating to how that appears elsewhere in the board papers. I won't discuss that further today, but I would like to highlight just one item. All health boards struggle to allocate substantially more money annually to preventative health actions, and of course this is reflected in our health board risk 008. Prevention takes many forms: vaccinations, medical, dental services and so on, but there are also specific projects overseen by the board, and one of these is the Healthy Child Wales programme, an initiative delivered by Health Visitors. Details are provided within the papers, and the report is valuable because it demonstrates the beneficial impact that even relatively small projects can make. It's also a good news story, and it also gives us a glimpse of the likely benefits of scaling up preventative projects in the future. Thank you, Chair.
Thank you. Does anyone want to come in at this point with a contribution in response to the PPPH report? There are none, so thank you, Robert, to you and your colleagues. And last but certainly not least, we go to the report from our executive committee and to the acting chief executive, Pete. Thanks, Pete.
Yeah, thank you, Carl. So the exec committee has met 5 times for the period we're reporting on. You will see that there's a significant number of items included in the report, but there is nothing to escalate or highlight further because most of these items go on to further committees or to boards, so they're covered elsewhere within the report. So nothing specific to raise, subject to any comments or questions.
Thank you, Pete. Once again, Simon, please come in.
Thank you, Chair. Simon Wright, independent member. Pete, could I just make an observation around the Financial Recovery Board? I'm very aware that this is in place due to the escalated status we are in, and that but kind of by exception, a subcommittee of executive is being reported to the board in this way, which is really welcome. The observation was whether it might be possible to explore providing a bit more information in the report around the movement each of those meetings is seeing on the savings plans in terms of what's changing in terms of deliverable savings and our confidence levels about those savings, and indeed what then specific actions are being taken to improve that position from one meeting to the next. And then I guess the final thought is whether that level of detail might be appropriate to go into the Finance and Performance Committee for sort of more scrutiny. So it's just really welcome to see it, recognise it's really important. Is there a bit more detail that could be coming through, and might that be appropriate to be considered in one of the subcommittees?
Thank you, Simon. So I was going to mention the Financial Recovery Board as a separate thing to the exec committee, but no, it's absolutely fine. So what I suggest is you note the actions and progress against the report. If we pick up that issue as part of the finance report and Hal's item, and then we can just check that it's meeting board requirements and also requirements in Finance and Performance Committee. So is that okay if we pick it up under that item?
That's fine.
Yeah.
Okay.
Great. Thank you.
Thank you, Simon. And actually, when we come to that item, just a bit of a heads up, Ronnie, as chair of F&P, I'm sure you might have an observation as well as to what your committee is already doing in terms of the financial scrutiny associated with financial recovery and escalation. So thanks, Pete. I can't see anyone else wanting to come in. So thank you, Pete, for that report, which takes us to item 1.8. Oh, no, sorry. Before we come to that, let me go to Helen. And Helen, do draw our attention to the information at the foot of the various reports, which lists the escalated items and their current status. Thanks, Helen.
Thanks very much, Carl. So there are 3 items that remain escalated to the board from various committees. The first, just to briefly run you through those, the first one is neurodiversity services are currently in level 3 local escalation. Our patient experience, quality and safety committee hasn't met since the last time the board met, but is meeting next week. So that remains an ongoing item on their agenda, and they'll be receiving an update report for that. That will come back into the board in September. As Ronnie mentioned, Finance and Performance Committee, along with a number of other committees, have a standing item on our organisational escalation status. That's our NHS Wales escalation status. This will be a long-term remaining item, but we will continue to highlight it and ensure it's reported. And then thirdly, but not finally, from Executive Committee is the escalated item around the cross-border functionality within the NHS Wales app. And Claire and her team continue to work on that with Welsh Government and DHCW colleagues, but there's no specific update to provide at this time. Thank you.
Thank you, Helen. Colleagues, do indicate if you'd like to come in. I wonder if I might just ask something or make a comment, Helen, just in the spirit of our conversations so far in this meeting about escalated matters, action logs and so on, and things sitting there for a long time or having lots of updates against them. I'm not sure how quickly the cross-border functionality matter in relation to the app is going to be resolved. And so my observation really is there's a risk that this will just sit there as an escalated matter for us as a board. It's beyond our direct control, and whether that is going to be very helpful. So I just wonder whether we need to give a bit of thought as to what we do with that escalated matter. Not that it's not important and not that we don't need to keep cited on it. It's just that as meetings happen, I'm sure we'll get to a point where we just say, well, you know, this is deja vu from meeting to meeting. Could we give that some thought, please?
I think that'd be really helpful, Carl, and you're absolutely right. The critical issue there being is that it is largely outside of our control, whereas the other two we have significantly more control and influence over. So shall we, we've got some time with our chairs forum in early September, and we've got action logs on the agenda. I wonder if we also add this item in terms of how we reflect escalation reports and consider it there collectively.
I'm content with that. Please do indicate, colleagues, if you aren't, or if you have a different suggestion. Okay, that's fine then. And I can't see that anyone else wants to make any comment or contribute in response to the escalation register. So thank you, Helen, for that. So that does take us to item 1.8, and we turn to our Regional Director of Llais, Katie, for her report. Thanks, Katie.
Diolch, Carl. Katie Blackburn, I'm the Regional Director for Llais in Powys. Llais is an independent statutory body representing the views of patients and communities, and we are not part of the decision-making process here today, so just to be clear about that. Before I sort of get into the report, I just wanted to pick up Rhiannon's observation earlier around recommendation 4. I think the same information was shared with the health boards as was shared with us, and we too, Rhiannon, have mentioned or raised the issue of the fact that there is only one question and how that's actually going to be, it's a very open question, how that's actually going to result in a sort of meaningful understanding of what the needs of residents and communities of rural Powys is. So just to pick that up there. With regard, and I'm happy to have a conversation outside of the meeting, Rhiannon, if that would be helpful. With regard to my report, I hope it's fairly self-explanatory. Just a couple of comments and observations since I last wrote it. We no longer have any outstanding representation, so my thanks to Helen, particularly in the corporate governance team, but to all of those who have been involved in preparing responses. I think we've spent quite a lot of time and work and effort, and we're really getting to where we want to be, both as a health board and us, in asking the right questions to get the right answers. So that was really helpful. With regard to engagement, we've been in Ystrad Gynllais, so we haven't yet had any feedback from that. And I've shared with board the events for the next quarter, just in case there are any board members who would like to join us for any of those events. Please feel free to drop us a line. We have a live document, which is all the events until the end of the year. So that was correct at the time of writing. We'll obviously also be attending all the Better Together events and also the JCC EMERTS events as they come, and then just a couple of website updates then. Chair, we agreed a couple of meetings ago that this would provide Llais with an opportunity to comment on some of the forthcoming discussions on the papers that are on the agenda today, and if that's all right with you, I just want to make a couple of observations really. Firstly, the Better Together paper. So from Llais's perspective, we will continue to seek assurance that the consultation process is inclusive, transparent and accessible. We feel very strongly from what we're hearing at the moment that people need to understand how the options that are being consulted upon have actually been developed and what the evidence is, the engagement, the clinical advice, other considerations, and what's informed those options when that discussion takes place. We are also keen, and I raised this at the deliberative event, we are also very keen to seek assurance that this is a genuine consultation and that people have an opportunity to actually influence the outcome, and that feedback will be listened to and will inform and influence final decisions. The consultation document does spend a little bit of time talking about some of the seldom heard groups, and it goes back to Simon's point earlier about online surveys. So we would want to be working with the comms team to ensure that, as I said, this consultation is as accessible and ensure that seldom heard communities and those who face barriers to participation are fully included in the process. And I think the other thing, the final thing really from this paper really is it's about building confidence, and it depends on how that feedback loop is closed so that people and participants and residents can actually see how their experiences and contributions have shaped the discussions and decisions and any future service improvements. Secondly, observation I'd like to make really is around it relates to Better Together, but actually relates, I think, to all papers, and I think it's something we've raised on a regular basis around travel rurality and cross-border care, and how that's a consistent theme, and how those issues must remain central to service planning. Helen's just touched on the neurodevelopmental services. We are obviously still hearing about the impact of delays in the assessment and support. And again, we would ask that, improving access and reducing waiting times remains a priority. And it was good to hear that it's on the escalation list. I think finally, from our perspective, whilst finance is not within the remit, or Health Board's finance is not within the remit of Llais, clearly the Health Board is facing financial challenges, and so it's about seeking reassurance that the patient experience and the quality of care and equitable access remain at the heart of transformation and financial recovery. Thank you, Carl. Happy to take any questions.
Thank you, Katie, and thank you for being so succinct and very to the point. Colleagues, do indicate if you have anything you'd like to comment on or ask about in response to the Llais report. But I wonder if I might just invite Nick to come in. The more generic, what we'll do, Katie, is that we will come back to your specific observations about specific papers at that point. But you do make a general point around seeking information about travel, particularly in our deeply rural context, and accessibility, cross-border impacts and so on, and the fact that we keep those as a central consideration in our planning generally, but also specifically related to our transformation programme. Nick, I wonder if you might just like to offer a response to that, please.
Thank you, Chair. Thank you, Katie. Obviously, we had the opportunity, or we asked for the opportunity and collaborated with you, that you presented the insights from the extensive engagement work that Llais do in your patient voice space as part of the development of our annual plan. And then we in that document, you can see how we responded to that in our planning. We work really closely with you in all our work around Better Together, and our continuous engagement activities. We know, as do you, that travel always comes out top of those conversations. For our population, it is a really high issue of interest and concern, both in terms of time, expense, are those journeys necessary, and so forth. And it is an area that we take into account in all our planning. Just to give one example, obviously we are developing a case for a standardised referral optimisation process and system for the health board. Not only does that mean that patient symptoms where appropriate will be addressed more quickly, it's part of our sustainability programme, but it also means that many patients won't have to travel for the care that they need. And we've got good evidence from the part of the service where we started that around MSK, the patient experience feedback is patients are really glad not to have to travel unless they absolutely need to, and that came out really loudly. So it is something that we always think about, and I think we've got growing examples of where we've taken action to reduce that where we can.
Thank you, Nicola. I can't see that anyone wants to respond to anything else in Katie's report. So once again, Katie, thank you for the report, and thank you for our developing constructive, positive working relationship. Always appreciated. Thank you. Colleagues, we're running a bit behind time. That's fine. We've given justifiable time to important matters so far. We'll try to make up a little bit of time, if possible, later in our meeting, but I do think we've earned a 10-minute break. So let's take 10 minutes, and we'll come back at 11:26, please. Thank you. Wel, croeso nôl, a dyma ni rwan yn ail gychwyn ein cyfarfod ac yn ail gydio yn ein hagenda. Very warm welcome back, and we resume our business today in our agenda at item 3.1, which is the update report of Better Together. I know we all know that Better Together is the name we give to our transformation programme, looking to the future of high quality, timely, safe services, sustainable services for and with the people of Powys. Just before we come to the actual agenda item, it may be helpful just for me to say that this matter is considered and is given very detailed and very considerable consideration outside of these public meetings. It's discussed every month at the executive committee, but as a full board, as a unitary board, we spend a lot of time in formal meetings and in informal discussions looking at this programme, its progress, and the processes around it. And so it's very, very important. And I just wanted to highlight the attention that this is given in this meeting and indeed outside of these meetings. It is something that, not surprisingly, our population and all stakeholders have a keen interest in. Also, not surprisingly, it is something that is generating some concern and a little worry. Change always does, and change as significant as this will clearly make people think, well, how does that affect me and my community and so on? And so we're very aware of that and certainly very alert to it. And so today, our agenda specifically focuses on an assurance update about the public consultation plan. And in a moment, I'll invite our Executive Director, Deb, to introduce the item and to introduce also some of her colleagues that will contribute to this agenda item. But just before we do, can I remind, particularly Deb and colleagues, of the comments from Katie that we've just heard, and ask please that these be addressed in the information that's shared and within the comments. So, and those were specifically around will the consultation be inclusive, be transparent and accessible, enabling all communities to participate? Also, how will we be able to demonstrate that the feedback has influenced decisions, and what will the feedback loop be, as it were, to those that have participated in those processes? And I think that in a nutshell summarises the Llais comments. So with no further ado, Deb, please do introduce this item to us and your colleagues. Thank you.
Diolch, Chair. So as you say, there are two papers on Better Together in public board papers today. The first is the assurance report providing an update on programme progress, and the second is the consultation plan that would be enacted should there be a board decision to move to consultation at some future point. We will present and talk through both papers before opening up for questions and comments. In presenting these papers, I'll be supported by Claire Madsen, Elaine Lawton, Adrian Osborne and Lucy Cornish. So dealing with the first of those papers, I'm going to run through a summarised set of slides. So slide 1. So today's presentation provides an update on Better Together Phase 1, focused on adult, physical, mental health, community services. The purpose today is to provide assurance on progress, the evidence informing the work and the steps being taken towards presentation of the pre-consultation business case in September. It is important to say at the outset that this is not a decision-making session. No decisions have been made about the future shape of services. The purpose is to show how engagement, evidence, modelling, clinical advice, pathway testing and assurance has been used to develop and assess potential future models of care. The presentation has 3 messages. First, why the current model needs to change. Second, how evidence and engagements have shaped the emerging future model. And third, the assurance and next steps towards pre-consultation business case consideration and consultation. Next slide, please. Better Together is our commitment to work with communities, staff, partners and the public to transform healthcare services for people in Powys. The core issue is that we must change how we work if we are to continue providing safe, high quality and sustainable services into the future. We are starting with adult physical and mental health community services because these are the services that most directly affect people's ability to remain independent, avoid unnecessary admission, recover well and receive joined-up support. This includes community hospital and mental health inpatient services, urgent care, mental health access and community teams, district nursing, home first, falls prevention, therapies, diagnostic and other services that support people at home or closer to home. The work is grounded in the shared health and care strategy for Powys, developed with Powys County Council, PAVO and the people of Powys, and now has been extended to 2028 through the Regional Partnership Board. The most important point is that this is not simply a service review. It is about designing services around future need, more prevention, more care closer to home, stronger primary and community care, and better integration between physical health, mental health, social care, and the third sector. Next slide, please. The slide shows the journey from early engagement through to the current technical phase. Better Together began in 2024, and since then the programme has been listening, engaging, and undertaking the detailed work required to develop robust options. Stage 1 pre-engagement helped us understand the wider context and the challenges people see. Stage 2 engagement then explored scenarios for adult physical mental health community services and helped shape the criteria that would be used to assess options. Since summer 2025, the programme has been in a technical phase, testing evidence, developing options, undertaking modelling and building assurance around whether options are viable and deliverable. There have been delays as additional options were introduced through internal check and challenge, but this has only strengthened the process by ensuring a broader and more robust appraisal. We are now moving towards finalising options that could be brought through into the pre-consultation business case for board consideration in September 2026, ahead of consultation if board agrees. The next slide brings together the main elements of the case for change: people, place and resources. Powys is ageing. The population aged 65 and over is projected to increase, while the proportion of people of working age is reducing. This means more people are likely to need care and support, while the workforce available to provide that care becomes constrained. Nearly half of the people aged 75 and over are living with 2 or more long-term conditions, and the number of people aged 80 and over has significantly increased over the last 20 years. These demographic pressures are not temporary, they are structural. The place element is also critical. The map illustrates the scale of rurality and sparse population, with each yellow dot representing an area of Wales that no one lives in. The average population density in Powys is around 26 people per square kilometre, compared to 2,620 per square kilometre in Cardiff. This has a real impact for service design. We do not have the population critical mass to deliver every service safely or sustainably in every location. Some specialist services require a scale of staff, expertise and activity that cannot be replicated across a rural county. Long distances from large population centres also makes recruitment and retention more difficult. The resources element is equally important. Powys has a different financial profile from other health boards, with a high proportion of our expenditure on services purchased from other organisations. The implication is that strengthening prevention, community services and local models is central to quality and sustainability. For the board, the key message is that future services must be designed around prevention, independence and coordinated community support, not simply more reactive or hospital-based care. The next slide brings together the key elements from stage 2 engagement. The central message is that people are not simply opposed to change. They want change to be purposeful, evidence-based and grounded in what matters locally. People told us they want stronger primary and community care, an integrated approach, prevention and early intervention, compassionate end-of-life care delivered by skilled staff, and strong partnership between health, social care and the third sector. They also recognise that some services may be organised differently, including through centres of excellence or regional rural centres, and that some specialist services may need to be delivered outside of Powys where that achieves the best outcomes. But they were also clear that services must remain equitable and rurality, transport, digital inclusion and access must all be considered in the plans. A key point from the local voices slide is the published papers, is that there is a strong civic pride in local services, including the contribution of communities, volunteers and unpaid carers. People also raise concerns about equity of access, travel to district general hospitals, cross-border care, communication and information following the patient, loneliness and isolation. Therefore, the emerging model has to do two things at once. Protect what people value about local care while creating a more integrated, preventative and sustainable model in the future. I'm now going to hand over to Claire. Thank you.
Thank you, Deb. Thank you, Deb. So my name's Claire Madsen. I'm the Executive Director of Allied Health Professionals, Healthcare Scientists and Digital. And this slide is particularly important, bearing in mind Katie's comments, because it demonstrates how the case for change is about quality and outcome for our population, not just capacity and finance. And the evidence on deconditioning and delirium shows that prolonged hospital stays can cause real harm to people, particularly for older people and people living with frailty. Slide highlights that up to 50% of older people may become incontinent, for instance, within 24 hours of admission. 50% experience functional decline, and between admission and discharge, 61% of old people develop a new disability and are not back to their usual level of function after 1 year. So the implication from this slide is clear. Hospital care remains essential for our population. However, it should be focused on people who actually need hospital care, and it should be time limited. They should be just there for the right length of time. Where it is safe and appropriate, helping people remain active, independent and supported at home in their own community can improve outcomes significantly. Next slide, please. So the national evidence tells us that unnecessarily or prolonged hospital care can cause harm, but we also have data from Powys that shows why this is important as well. We continue to see high levels of hospital activity, long lengths of stay and increasing demand from people living with frailty, dementia, multiple long-term conditions and complex physical and mental health needs. The slide shows over 37,000 out-of-county admissions, generating almost 100,000 bed days in 24-25. And the average community hospital stay is around 40 days, which is almost double the Welsh expectations, which say we should expect around 21 days. It also shows that almost half of the people in our community hospital beds are clinically ready to go home, demonstrating the need for stronger community alternatives and discharge support. The fuller presentation in your papers also shows that includes patient pathway testing, a rapid review of community hospital inpatients, and a week of care review of emergency admissions. That testing showed that a significant proportion of hospital activity could potentially be prevented, shortened, or managed differently through a stronger community-based model. But the key point from this slide is that the case for change is not based on one source of evidence. It's supported by national evidence, local data, pathway reviews, and engagement. Together, they point towards stronger prevention, earlier intervention, integrated physical and mental health support, more care at home, and better rehabilitation and recovery in the community. Next slide, please. So this slide is also important to emphasise that the future model is not starting from scratch. There are already important building blocks in place across Powys. These include access developments such as our single point of access, our 111+2 service in our mental health services, and our digital services. Prevention work around frailty, early intervention, and community support, and alternatives to admissions such as our virtual wards and crisis response. We have recovery and independence services such as reablement, intermediate care, and discharge support. And we have increasing integration between physical, mental health, social care, and we work closely with our third sector organisations within Powys. Better Together brings these developments together into a more coherent model. The aim is to move away from fragmented or isolated schemes and move towards a system-wide approach that can be consistently understood, resourced, and delivered. So the message for Bwrdd is one of both confidence and realism. There is already progress to build from, but the evidence tells us that incremental improvement alone will not be sufficient to meet our future needs. I'm handing over to my colleague Elaine now.
Thank you, Claire. So this slide shows the structured route that we've taken from case for change to consultation. We started by identifying challenges and opportunities through the case for change, supported by technical chapters on community services, primary care, mental health, and diagnostics. And we then moved into ideas generation through engagement with citizens, staff, communities, and stakeholders. Those ideas then needed to be translated into options. Hurdle criteria were used to test whether ideas were feasible enough to proceed. Assessment criteria based on the duty of quality domains, safe, timely, effective, efficient, equitable, and person-centred, were then used to test those shortlisted options. These criteria were informed by user and staff feedback during stage 2 engagement, so they reflect what people told us matters. The fuller deck also sets out the assurance underpinning this work, including staff and user insight, benchmarking, independent clinical advice, demand and capacity modelling, strategic assessment, and partnership working. It also referenced learning from other service change programmes, independent advice and assurance, independent consultation insight, CLICE, and staff-side participation and external review. The key assurance message is that options are not being developed through preference or opinion. They're being tested through a structured, evidence-based, engagement-led and independently challenged process. Next slide, please. This slide brings together the emerging future model across mental health, physical health, and urgent care. The important message is that these should not be seen as separate models, but as parts of one integrated physical and mental health community system. The mental health model is described as an integrated recovery-focused system, an early intervention and no wrong door access. It spans prevention, crisis, inpatient care and recovery, with a strong emphasis on community-based support, crisis alternatives and integration with physical health. The physical health community model focuses on proactive prevention, rapid, time-limited intermediate care, multidisciplinary place-based teams, urgent community response, rehabilitation, and hospital at home services. It's designed to improve independence, reduce avoidable admissions, and enable safe discharge. The physical health inpatient model is not about saying beds aren't needed. It clarifies the role of inpatient care within a wider system, a step up, step down, rehabilitation, complex care, mental health inpatient support, and end-of-life care where that's required. The urgent care and diagnostic model strengthens timely access to assessment, diagnostics, and treatment for non-life-threatening conditions, aiming to reduce avoidable emergency department attendance and unnecessary travel out of county where that is safe and appropriate. So the overall shift here is from fragmented pathways to one coordinated approach. Earlier prevention, simpler access, faster community response, inpatient care focused where it adds most value, and stronger recovery and independence. Next slide, please. So behind all the modelling, analysis and option development are real people like Delith. So Delith is 75. She lives independently on a farm in Powys. Welsh is her first language. She's got vascular dementia and experiences delirium during a UTI, raising both physical health and mental health support needs. Today, Delith's pathway risks becoming fragmented. Physical and cognitive decline may be recognised late. An acute episode may be managed outside of Powys. Her family may carry the coordination burden, and inpatient care may be considered separately from wider support at home and in the community. The future model is designed to feel different. Instead of multiple services and multiple plans, Delith would have one coordinated team around her, bringing together physical health, mental health, independence and wellbeing needs into a single pathway. This means more support to stay safe at home, earlier intervention when her needs change, integrated monitoring and step-up care, and specialist inpatient care when that's required. The slide also highlights better continuity and support for individual needs. This is the practical meaning of the future model: less fragmentation, fewer handoffs, more support at home, and one joined up team working together to help people stay independent, well, and connected to their community for as long as possible. The message from this slide is important. Better Together is not simply about changing services. It's about changing the experience of care for people and families, from navigating separate pathways to being supported through one person, one plan, and one pathway. Thank you. I'm going to hand back to you now, Deb.
Thank you. So next slide, please. So no decisions will be made until there has been full and meaningful consultation with the public and staff about the future of community services in Powys. The consultation is expected to ask important questions about how we ensure a greater focus on preventing ill health, how we strengthen primary and community services so that more people are supported to stay well in Powys, and what the right future model is for bed-based services. A pre-consultation business case is currently in development and will be brought to board in September for a decision on whether to proceed to consultation. If board agrees, consultation will then provide the opportunity for formal public and staff feedback before any future decision is made. The key dates are: board papers are published in the week beginning the 7th of September. Board decision on launch of consultation is on the 16th of September. Public consultation will run from the 21st of September to the 13th of December. And then we enter a period of conscientious consideration of all of the feedback in Q4 of 26-27. A post-consultation business case will be considered by the board in spring 2027. In closing, the evidence, engagement and assurance work to date all points towards the same direction: future health and care needs in Powys are most likely to be met through a stronger focus on prevention, integration, recovery, community-based support and care closer to home, whilst ensuring that inpatient and urgent care services are available when needed. As a reminder, the board is not being asked to make any service change decisions today. The board is being asked to take assurance that the work has progressed through a structured, evidence-based and engagement-led process, and to note the route towards pre-consultation business case consideration in September. I'll now move on to the second of the papers. And this second area is the consultation plan that would be used should there be a decision to proceed to formal public consultation. If we now turn to that paper, and I'll be supported on this item by Adrian Osborne. So together I'm introducing the proposed stage 3 formal service change consultation plan for Better Together phase 1 and seeking the board's approval of that consultation plan whilst recognising the pre-consultation business case itself will not come before board until September. I'd like to begin by emphasising that this paper is about how we will consult and not what decision the board should ultimately take about services. As stated earlier, no decisions have yet been taken on the future shape of adult physical or mental health services in Powys. Today's discussion is about ensuring we have a robust, transparent and legally compliant process in place should the board decide in September that options are ready to proceed to formal consultation. If I may, I'll now hand over to Adrian.
Thanks so much, Deb. So I guess as we've heard quite powerfully there, our health services in Powys face some significant opportunities and challenges if they're going to be safe and sustainable for the future. And I express an interest here, as many of us do. I'm an ageing Powys resident, so bluntly, I've got a few years of my remaining working life during which I can help create a health system in Powys that I and others feel safe to grow old in. And that's certainly something that focuses the mind right now. So the scale of the potential options that we're considering are reflected by the model of care we've just heard about. These definitely reach the threshold for formal consultation set out in Welsh Government guidance on service change. There's a detailed guidance available online about what form and nature that type of consultation should take. And as Deb said, I stress that consultation will only take place if it's approved by the board following consideration of the pre-consultation business case in September. But ahead of that recommendation, it's vital that we do start some detailed planning so that we can ensure a fair and compliant consultation process that enables our citizens, our staff, our partner organisations to understand the work that's taken place so far, to test it, to ask challenging questions so that decisions can be made next spring that take full account, take conscientious consideration of all that's been heard. So the consultation plan presented to you today sets out the framework in which those activities take place. It's been developed to reflect recent legislation, relevant legislation, policy, best practice advice. We have independent assurance in place from an organisation called HICO, with their feedback being fully reflected within the plan in front of you. The plan has also been developed and reviewed through our organisational development, engagement and communication work stream, and that includes staff side and CLICE participation, CLICE clearly in an observer role, reflecting their independence. And again, the feedback that we've received has been fully reflected in the document before you. So I guess a key question for the board is whether this plan, if delivered, would enable us to meet relevant compliance requirements, essentially both to undertake a satisfactory consultation and therefore also mitigate future risks, for example, in relation to challenge or a judicial review. So, for example, it's vital that we set out in this plan the activities that we can deliver, have capacity to deliver and are sufficient to meet our requirements. I know there's lots of things that we could do for a consultation, but this focus on the things that we must and should do, and these form the focus of the plan. And it's also important that we reflect and review during consultation, particularly at the midpoint, so that we identify and agree further steps that we need to take, reflecting on our learning of delivering the consultation plan so far. So based on the assurance processes that we've had in place, my recommendation to whether the board can approve this plan is yes, this sufficiently meets our relevant compliance requirements. And some examples in the plan include there will be a public drop-in event in each of the 13 Powys localities, reaching out to communities across the county. There'll be outreach to community groups to ensure we hear voices less heard. There'll be public focus groups that are independently facilitated by an external analysis company, ORS. There'll be inclusive materials such as easy read, audio, and there's a wide range of accessibility features built into our website as well as providing print information for those who need it. As I mentioned, the plan includes independent analysis from ORS of the views that we hear, and I think this will give the board and the public greater confidence that the issues raised are being presented to us independently, and we are hearing the issues that people are putting to us. And importantly, in the plan, it also expects that we give time for that analysis, that we ensure as a board conscientious consideration of what we've heard, and that the conscientious consideration is seen to inform the post-consultation decision case before any decisions are made. Clearly, alongside this, the role of Llais is incredibly important as an independent citizens' voice body, hearing views from the people of Powys, which will also contribute to their own responses and representations, which the board must have due regard of. So in relation to this plan, there are a couple of issues and risks just to draw the board's attention to. If we are to launch consultation on this schedule, we will incur some costs associated with consultation ahead of that September decision, because it's important that we plan and enable people to respond, as we've so clearly heard from Llais and members of the board earlier. So, for example, we will need to begin to advertise some activities such as locality drop-in events ahead of the board decision because we want to give residents enough time to plan to attend. So the board's asked to approve the consultation plan today, noting that it doesn't prejudge or preempt any decisions to be made at the board meeting in September when the pre-consultation business case is received. Instead, today's decision is about confirming the framework through which consultation would be delivered, so that detailed planning can now take place in readiness for your decision. And this will also be an open and transparent process so that we share with the public how their feedback informs the recommendations following consultation. That's so important that we're seen to share the independent analysis of what we heard, that we demonstrate how that contributes to the post-consultation decision case, and that we feed back to our communities about their voice is informing and influencing the decisions the board makes. So I therefore commend the plan to the board today for approval. Thank you both. Deb, does that conclude your presentation, or do you have any closing remarks?
No closing remarks other than to say, a big thank you to the team for supporting today, and for the teams that are not even present that helped to get us to presenting these papers today. But I'll hand back to you, Chair, for any comments, questions from others.
Thank you. Robert, please come in.
Thank you. First of all, on the communication plan, it's very thorough, reflects the considerable expertise and experience of the team, and I have confidence in that plan. As always, a huge amount of work being done in the background on Better Together. I'd just like to make two observations on preparing and presenting content for the further discussion. And if these are, if this will appear as teaching a grandmother to suck eggs, and I apologise, but I think some of the issues will resonate with members of the public. First of all, we have to have unambiguous clarity on the exact nature and the impact of any proposals when the time comes. For example, the inclusion of alternative ways of accelerating urgent care is very interesting. We've had these types of plans, MIU Plus, in our strategic plans before. Urgent care centres are mentioned. There'll be lots of interest in this, what they will and will not do. We don't want to unjustifiably raise expectations, what added value they will bring, what exactly can we do within Powys, within our budget. I'm sure that future plans will make these things clear. And second, Better Together is a programme that develops alternative ways of doing some things, but it also relies on continuing to do some things well while demand increases. So the success of any proposal depends on there not being a weak link in the chain. Take, for example, general medical services. Is there parallel innovative work being done to ensure that the capacity of that service is likely to be able to support the growing elderly population and so complement and not hinder the proposals that will emerge from Better Together? I acknowledge the phrase strengthened primary care in the document, but I think that the concrete details of how precisely that service will be maintained are as important as a description of the new ways of working that will emerge from Better Together, especially since primary care is already a red scored risk on our risk register. I think we should include that assurance at the same time as the detail of the other Better Together proposals. This may well, of course, be the plan, but I do believe that this subject will be of substantial interest to all Powys residents, and that addressing it in our consultations will confer even more credibility to any Better Together proposals. And of course, we could make similar comments on delayed transfers of care, which also has the potential to severely reduce the benefit of any changes. Thank you, Chair.
Thanks, Robert. Deb, do respond or bring in others to respond to Robert's comments and questions, please.
Lovely, thank you. Can I bring in Lucy on Robert's points about weak link, etc., and then Elaine for primary care?
Thank you, Deb, and thank you for your questions and comments, Robert. So just in terms of your request for unambiguous clarity on the models and expectations around future models of care and the detail, particularly in relation to the scope of urgent care provision, etc., that will all be included in full through the pre-consultation business case that is presented to board in September, and then through into consultation materials, so that we can provide the clarity in terms of the proposed scope of services and our confidence in the ability to deliver those and the impact of that on the population. Just providing assurance around that, Chair. I know Elaine's going to come in relation to general medical services and primary care. I think just to note that we are aligning our plans with national work around community by design and the emerging plans around that, to ensure that our community model that is in development supports those initiatives that will further drive that improvement through primary and community care in the future. But I'll hand to Elaine. Thank you.
Thank you, Lucy, and Robert, thank you for your question. I think the point around general medical services is really critical. I think there's two key components of that. So the first of those is, what is it that we can directly influence around how individual general medical service providers, so our GP practices, evolve and develop and can respond to the ageing demographic that we have, not just within Powys but across Wales, but increasingly so within Powys. And I think some of that we can influence, some of that is led by the national negotiating teams that hold and manage the contract development. And there is commitment at this point in time in terms of developing general medical services. I think the critical bit, though, that we can really make sure that we can deliver through Better Together is how we develop that community model, how we build that and wrap that around and with general medical services. I think that's got to be the most important element. And when we have conversations with general practice, a lot of their decisions are made on what they know about the services that they can access outside of their building for their patients, for our population. So that's a critical component part of the community model that we're developing and proposing through Better Together.
Thank you. Robert, do you have any additional comment or question?
No, thank you. Thank you very much.
Okay, let's go to Simon, please.
Thank you, Chair. I had three comments and questions around the consultation plan, if I may. So first, thank you to all of the teams. There is a significant body of work going on here, and this presentation today really does shine a light on just how much work has taken place already and how far along that journey we've come, and how strong the due diligence has been in looking at the options and building the case for change and the consultation plan. So thank you for that. I was really pleased to see the Delith story in the presentation today, and that really prompted me to just ask and seek some assurance that we're going to be able to see some more of those kind of persona stories developed as we go out to consultation. They really do help, I think, to explain how things will improve for individuals in their communities. So I'm keen to see more of that as far as we're able to develop it. Similarly, wanted to check, are we progressing an assessment of what the changes might mean for individual communities? We saw that coming through some of the deliberative event feedback. So just wanted to check how far we're able to progress some of that thinking in the consultation. Third point I wanted to pick up was a reference in the consultation information around consideration of further events, and I'm very mindful that we do have limited capacity and we can only work within the capacity that we have, and that will we have some clear criteria by which we're able to judge whether or not we can undertake additional activities and additional events, given the high level of interest there's going to be from a very broad geography and quite a lot of perhaps more local structures seeking to invite us into events that they're running. Also being mindful that we have to be careful not to create inequality in terms of attending an event in one area and then because we haven't been invited to, not being present in equal terms in other areas. So just mindful that we need to be careful about that. It's just really a check whether we're going to make sure we've got some kind of criteria by which we'll judge if we say yes or no to invitations that may come in around additional activity. Thank you, Chair.
Is that back to you, Adrian, initially, or?
Really happy to come in on those, yeah. Yes. I think on the personas, that's a simple yes. We're working on a range of case studies that help to bring to life the potential impact benefits, but also potential downside impacts of the options that are under consideration. And linked to that, very much anticipating that within the consultation information that's published, we'll be seeking to identify the impacts on a locality basis. So colleagues are aware that we tend to plan on a 13 locality basis within Powys in terms of population planning. So we're looking at an impact statement for each of those 13 localities. Ideally too, as the consultation progresses, not necessarily at the outset, but as we move forward into those locality events, actually having some of those persona case studies on a locality level as well, so that as we're visiting each community for those drop-in events, we're able to explain on a more granular basis what that might mean in that community, recognising Powys is large, isn't it? Our experiences in different parts of the county vary a lot. The pathways in Fachlen, Llanrydr and Mochnant will be so different from those in Ystrad Gynllais, Hay-on Wye to Machynlleth and all points in between. So trying to provide that localisation is something we very much aspire to. Important point too about events, and fairness is that real starting point. So the consultation plan is very much based on that fairness of us proactively reaching out, about us seeking voices less heard. If we're too drawn by saying, well, attend this event, that event, the other, then we risk giving preference rather than fairness. A key point in the process will indeed be the midpoint review, because actually that midpoint review is a really timely opportunity to say, who are we hearing from, who aren't we hearing from? So therefore, where there is discretionary capacity to do more, then we target it into the areas that we haven't already been hearing from during the consultation, to really build that idea of fairness and voice right into the heart of this consultation, so that we give people confidence they've had the opportunity to contribute, and we give people confidence too that those voices will be influencing the decisions that are made following that consultation. I hope that's helped.
Really helpful, Adrian. Thank you very much.
Right, let's go to Mick. Please, Mick.
Thanks, Chair. I think in a sense, my observations and a couple of questions that have largely been covered, but I think, this is a really significant issue for the board, and I think it's probably worth just sharing perspective so there is a range. So for me, this was a really helpful and very timely paper. Actually, I've followed the progress of Better Together incrementally over the last 2 years, and, it's been a challenge to keep pace at times, but this paper for me, in conjunction with the paper in the private part of the meeting, it just brought it all together in a very cohesive and compelling way that I found relatively easy to follow and understand. So I wouldn't say it was a light bulb moment, but it certainly, brought things to life for me. I think the papers and the presentation make out, the case for change in a very persuasive way. And in particular, I'm reassured, I'm assured that a great deal of thought has gone into designing what, by any standards, having seen a few of these, is a very comprehensive and very wide-ranging consultation process, and one which genuinely puts stakeholders and public participation at its heart. So in that sense, just to nail my colours to the mast, I'm very content to support the recommendations and very content to approve the consultation plan. I just had 2 questions and observations, which Robert and
Simon.
Sorry, Simon. Robert and Simon covered, but I think more to do with how we're going to do it rather than what we're intending to do. So the first one was around community concerns that decisions have already been made. You raised that in your opening comments, Carl. Kate alluded to that in her input. So just a question in my mind about how we're going to give our communities the same level of confidence that I think we have as a board, that this is genuinely a point at which they can influence the eventual outcome, rather than just comment on things that are largely settled. I don't think an impacted presentation like the one we've had today or a detailed paper is going to do that. It's something more intrinsic that will convince people that this is a genuine opportunity. So just, interested to hear any further thoughts on that. And then the second question for me was, the options for consultation are, by virtue of the fact that we are genuinely seeking people's views, they're quite broad. And as Simon alluded to, it might be quite difficult for people to envisage what that means for them on a day-to-day basis. So I was just interested, as Simon was, and we've discussed this, how we bring this to life for people, how we make them able to see what it is that this means for them. And we did have quite a detailed conversation about it at Board Development Day, but it's helpful, I think, to rehearse it in a public domain. And I suppose, just a final observation, time is now of the essence. We're a month away from September when the board will need to approve this. So there's just a question about what's practical in terms of bringing this to life, making it feel like a genuine opportunity in that short space of time.
Thank you, Mick. Again, is it Deb? Should we go to you first, or do you want to hand over to Adrian?
Excuse me, I'll try and respond first. So in terms of giving the communities a kind of, genuine understanding and making them feel part of it, what Adrian's described is helpful in terms of getting out there. We've also stood at more regular conversations with our staff, lots of whom will be members of those communities. So one, to make sure that they understand where we are in the process. Secondly, that they understand kind of perhaps some of the misinformation that might have been kind of put into public domain, but that they have an opportunity to influence and hopefully be a voice in their family group, their community. In terms of the bringing it to life, you know, we acknowledge that not everybody is going to read really long business cases, but it would be really important that it is in easy everyday language, that means people can understand it. It will be supported by some visuals which describe things like the Delith journey, so in those personas. So I wouldn't want people to be concerned that because they haven't seen all of that today, they aren't things that we're working on behind the scenes in anticipation of where we might be in September. I don't know if there's anything else you wanted to add, Adrian.
Thanks very much, Deb. Really, really important points there. And I think it acknowledges that a challenge for all of us when we launch consultation is that this is not a referendum. It's a vital and timely opportunity to test and to challenge ideas that have already been informed by thousands of voices over the work that's taken place over the last 2 years and even previously. So I recognise there will be some of those issues in public confidence about the degree to which they can influence decisions, because again, as we've heard in our earlier presentations, our consultation is likely to focus, subject to the views of the board in September, on a suite of options. This isn't now a blank sheet of paper, because a lot of very detailed work has been undertaken to think what's clinically feasible, what's safe, what's viable, what can we make happen, and how do we adapt that into the very unique challenges and opportunities presented by a county like Powys, where we have no feasible opportunities to provide, for instance, a district general hospital within the county. We don't have a large enough population with a critical mass. We have to find new and unique ways to do that suit our context. So having that suite of information, enabling people to access visual, simple, easy read versions as an entry level, drill down into the detail. The papers that the board receives in September will be a suite of very detailed technical supporting documents as well that help those who wish to drill into the detail of the very careful consideration that's already been taken of demand, capacity, workforce, finance, travel, clinical compliance and clinical governance. That detail will be there for people to scrutinise, and hopefully that will be a key part of the confidence that we can give to people as well.
You content, Mick?
Yes, thank you. That's helpful.
Thank you. We do have several colleagues still wanting to contribute. I am conscious that we are running significantly behind time in this meeting. However, these matters are very important, and it is equally important that we give them the time that they deserve and the time that they need. So I'm not going to stifle discussion in any way. I would please ask for brevity, and if anything in terms of question and so on has been asked before, then please try not to repeat it. But let's go to Steve. Thank you.
Thank you, Carl. Yeah, just very briefly, just to support other colleagues' comments, and in particular to support the comments about developing other personas. I think that's really important to bring that to life. A specific question in terms of the consultation plan was how we intend to engage with our primary care colleagues, because they obviously have a critical role to play in bringing the future models of care to life. So I know they're referenced in the plan, but I didn't see anything quite as specific about how we will engage with them, you know, separate to other engagement processes. So perhaps if you could explain that. Thank you.
Thanks, Steve. If we just hold on to that specific question, please, and invite Rhiannon to make her contribution.
Thanks, Carl, and also acknowledging the maturity, I suppose, in terms of this particular slide deck. I think it's really helped to bring the confidence and bring the strands together. My 2 points specifically is around how are we looking at the cumulative impact on communities in the context of any transformation programs that the council is having, particularly that sort of, you know, what we're doing, what they're doing, and the potential of cumulative impacts, positive and potentially negative. And my other point really is around prevention, quite rightly, is mentioned a lot in the presentation. But I think it's really quite important that we distinguish whether we're talking about primary prevention or secondary prevention. My understanding is I think we're really talking about secondary prevention. The types of things that Robert was talking about earlier in the kind of early years aspects of obesity pathways, shifting money into prevention that actually takes a lot longer to be realised is a different kind of lens on prevention. So I think it's just being clear about earlier intervention, prevention across the life course, probably more in the sort of upper age range of prevention. Thank you.
Thank you. Deb?
Can I bring Lucy in, please, Carl?
By all means.
Thanks, Chair, and thank you for your questions, Steve and Rhiannon. So just in terms of response around the primary care engagement, we have a wider pre-consultation engagement plan with all our partners and providers, of which primary care and GMS colleagues are a key partner. So we have, over the course of this work, run a series of quarterly workshops with our primary care and specifically GMS colleagues, recognising where we are in the process. They have also been invited to participate in our deliberative events and other engagement activity. We have had a recent workshop session, so half-day workshop session since our deliberative event with primary care colleagues, and are in the process of booking a series of practice level discussion sessions over this coming period so that we can have further conversations at a practice level. We are engaged with a collaborative and cluster level also, and then have further workshop sessions scheduled in over the coming months into the next 2 quarters as well, where we will be further continuing this conversation, but at a more specific primary care GMS level. So hopefully that provides assurance in relation to that aspect. I will add that provider and partner engagement plan also includes all of our providers and wider partners as well, to ensure that we are having those ongoing conversations with all of our partners and giving them the opportunity to both engage and participate alongside the consultation period, which, subject to approval, will go live in September. So just then in relation to...
Lucy, I'm sorry to interrupt. Can I just ask a bit of clarification? When we talk about primary care, are we talking about the breadth of primary care? So you talked about workshops and events and so on. Or are we talking specifically about GMS and GP practices?
So our primary care workshops have included wider invitees, but they have had a GMS focus. So they have included invites to collaborative leads from all professional collaboratives within the clusters, but with invites to, at a practice level, to all practices to send a representative. So they've been primary care sessions with a GMS focus, Carl, and the forthcoming sessions will continue with that format, also with the GMS focus, but wider primary care representation also, and then those practice level discussions will obviously be GMS focused discussions.
Thank you. Sorry, I interrupted you, Lucy. You were going to go on.
That's okay. Thank you, Chair. So just moving on to the questions around the cumulative impact with social care. Just for assurance, we have a regular interface with our partners and particularly with our adult social care partners. We have identified some areas of joint priority for working and have our interface through both joint leadership team, but also through separate transformation related discussions and meetings to ensure that we are aligning in terms of our planning. So those are in place, and at this point in time we're not identifying any conflict in planning that would lead us to consider that there are any challenges in relation to the elements that we are seeking to take forwards into consultation. In terms of prevention, absolutely acknowledge the comments around primary versus secondary prevention and the need for clarity in relation to that. We obviously have the board approved population health framework, which we will be seeking to reference within our pre-consultation business case as an important background document and framework for the organisation, which links through to Better Together as well. Thank you.
Thank you, Lucy. If there are no other, Steve, you, Rhiannon, you content?
Yes, thank you.
Yes, thank you.
Okay, let's go finally then to Kathy and to Chris. Please come in, Kathy.
Yeah, Kathy Poynton, independent board member for trade unions. I don't particularly want to ask a question, but would like to inform colleagues about staff involvement in Better Together and the process that's gone forward. What we have to remember is staff are for change. They want the change. They were asking for changes before Better Together was started. So they have been involved in the main, not all staff, I will hold my hands up there, in giving ideas, in giving feedback. They have attended team meetings, departmental meetings, service meetings, plus the deliberative events and anything else. And they fully understand and want to embrace a change because they know their contribution and what they put forward will make an improvement to patient care, their working lives, and the quality of care that patients receive. So while not everybody is happy about it, I would say that the majority of staff are, and that they do actually realise this is, I hate to use a managerial term here, but this is a marathon and not a sprint. And they know that big change takes time, but they are all for it if it will improve what they can do during the day. And a lot of them being very impatient that they want to see this change happen now.
Kathy, thank you so much. That's a really helpful contribution. And just for those that may not be aware, I think particularly having your input as our staff side and trade union independent member on the board is particularly helpful and useful. So many thanks. Chris, please.
Thank you. I can see that a process has been followed, and I also welcome the communication plan that's mentioned in the, particularly around the outreach proposal, because I think it's really important that we can engage with those people that may not be digitally active so that we get their inputs within it. I think it was mentioned that we're going to take stock in around the halfway stage to those where we've got gaps in that consultation. And I just wondered whether there's any lessons learned from previous engagements of where we note that there is a particular group or contribution that doesn't come in, it's limited, so that whether we can work proactively to address that going forward. I think that we also need to focus this around, there are people that are utilising services in the here and now, and there are those people that are going to be accessing services going forward. So therefore, if it's going forward, we can put the preventative model in, which is in place, and it's how we fit those two pieces together, because they could be repel and they could become poles apart, and I wouldn't want that, because the most important thing in my view is that we have safe and effective care which is of a high quality in whichever direction we go. I was also interested within the integrated model. I think that is really helpful, and it's not just about better to get together, it's also about working together. So my question was, and I think Lucy gave some of the indication that there has been work with the local authority, and I welcome that, because that partnership collaboration is really key and important, because a change in the local authority can also then have an impact on the health board as well, and vice versa. And on the but yeah, I can see that this has been worked through. Finally, if we have these consultations coming through, just picking up on a point that was made earlier about dual consultations going on with another body, does that confuse things, and could that put us off track? And if any ideas do come through from these events, how are they then going to be worked through? Because if we leave it until the December before that's then considered, does that then give us enough time to reflect on that and work up any additional proposals that the board would then need to consider? And I'll stop there, Chair. Thank you.
Thank you, Chris. Some observations and one or two questions, but let me come to you, Deb, and you bring in whoever you think is best placed to respond.
Lovely, thank you. I'll hand over to Adrian and Lucy for Chris. But can I just pick up on Kathy's points? I think it's really important to understand the extensive conversations that have taken place with staff. More to come, I know, but really important that we understand the staff view, and that, you know, lots of people have been asking for a change going forward. What we change to, if we change, it remains to be seen, but that engagement with staff and staff side in particular is important. Lucy, Adrian, do you want to pick up on Chris's point, please?
Thanks. Some really helpful points there. I guess across a county like Powys, one particular cohort that I would draw attention to where we'll need special attention, carers is a great example, isn't it? Carers by definition have less opportunity to leave the home. They've got caring responsibilities, making sure that we take active steps to reach out to them, potentially given the impact of these types of proposals on them, will be an area that we'll want to ensure focus on. And I include within that young carers as well. Important for the board to recognise that these proposals mainly relate to adult physical and mental health community services, but there are a couple of really important interdependencies that affect all age services as well. So we're talking about minor injury units. Minor injury units in Powys are open to anyone age 1 and over. We're also referring to some all-age diagnostic services as well. So our consultation will need to make that clear, and our consultation therefore needs to reach out to children and young people, both the service users as young carers, as the future adults as well. Really important audiences there. You raised some important points there about options. I mean, this is exactly the purpose of the consultation. As I said, this isn't a referendum. There's something here about really retesting and testing the thinking that's taken place so far. Have we missed important options? And as part of the supporting documents, we'll be making clear some of the options that we've considered and why some have been discounted. Have we been using the right criteria to judge those options? Are there important factors that we've missed? We will be listening to that in real time as the consultation takes place, but it's also really important that we give due regard to the aggregate of it. Take account of that when the consultation ends. What have we heard during that 3-month period? That's why those phases of analysis, including independent analysis, are careful and conscientious consideration as a health board, and then that informs the post-consultation decision case, which we should expect to see in the spring. So December is the end of the period of the consultation based on the current plan, without prejudice of the decisions of the board, but those following months are the ones where we do exactly that. What new options have we heard? What new factors do we need to take into account? How does that then help us to develop an updated suite of recommendations to the board in the spring? And we can also look to our neighbours on that as well. So Hywel Dda, for instance, last year undertook a very comprehensive consultation across 7 service areas. In one of those service areas, they had identified new options, so have recently been retesting those, as was referenced in the Chief Executive report earlier. You mentioned too about some of those sort of interdependencies and confusion potentially with other consultations taking place. That is something we always seek to keep track of, and there'll be something really important for us, particularly in our consultation events, about them keeping them focused on this consultation. People may well come with other issues, but we will want to keep some ring fence around it so that we reduce the confusion rather than increase it. Sometimes in these events people say, well, can I bring this issue, can I bring that issue? We've got to try and make sure these help us consult on these really significant and important issues, because it's so vital, isn't it, given the challenges that we face, given what we heard from Kathy about those experiences from our staff, that we make some decisions that truly help us create safe, high quality, sustainable services for the future. The longer this takes, the more we're sitting on those very risks that you have in the corporate risk register that are affecting quality, they're affecting safety, they're affecting outcomes, they're affecting working lives across the county.
Thank you. Do you have anything to add, Lucy, before we invite Deb? No? Okay. Deb, do you have any closing comments?
No, I don't, other than just to thank everybody for their important contributions and comments. Clearly, we still have a process to work our way through, so lots of activity in the coming weeks, but I'm conscious we've taken up quite a bit of time on this agenda, Carl, so I'll hand back. Thank you.
But quite rightly so, and a big thank you from us to you, Adrian, Lucy, and the teams and colleagues behind you for bringing us to this point, which has been no mean feat in and of itself. And so, colleagues, let's go to the recommendations. We have 2 papers for our consideration, as we've acknowledged. I'll take the recommendations separately. So initially, on the assurance paper, we're asked to note the updated position. We're asked to take assurance in relation to the progress towards presenting the options for phase 1 of Better Together. And we're also asked to note the timeline for presentation of the pre-consultation business case to us as a board, currently due in for our September meeting. So would you please indicate if you want to comment on that recommendation or dissent from it? No one is doing, so I therefore assume that that is supported unanimously. And secondly, the consultation plan paper, we are asked to approve the consultation plan, recognising the pre-consultation business case will be considered by us as a board in September. We're also asked to note that the review and assurance of the consultation plan continues to be undertaken by our external consultants, HICO. So once again, colleagues, please indicate if you want to make a comment or if you want not to support the recommendation. That therefore also is approved and supported unanimously. We will be taking a lunch break. I know we are due for a lunch break at 1 o'clock. It may be, colleagues, that we won't have finished or concluded all the business that we were scheduled to conclude before lunch, in which case we'll probably need to adjust our timing of things a little bit, but we'll try not to delay lunch too much. But let's go now to another very important paper, our financial performance paper, and I'm going to turn to our Acting Director of Finance, Howell, to present this. Thank you, Howell.
Thank you, Carl. Howell Pullen, Acting Director of Finance. And Carl, can I start by thanking you for welcoming me to the board at the beginning of the meeting. So the month 3 finance report highlights our financial performance, both in the terms of day-to-day expenditure for revenue and also our expenditure on capital assets. And you'll read that after 3 months, we are £1.8 million off our profile in terms of our revenue financial performance, in that we're £13 million overspend against a planned deficit of 12.2 million. Good news, though, that in month 3, we have remained at £1.8 million overspent. In month 2, we had also been at £1.8 million. So in the month of June, we have broken even on our budget as planned. In terms of capital resources, we have an allocation this year from Welsh Government of £9.5 million and have plans to spend that fully by the end of the financial year. Newly introduced to the financial report in this month is also a focus on our public sector prompt payment performance, and you'll see that this is an area that we are not achieving the target of 95% for non-NHS suppliers, and it's an area where we're looking to improve through the remainder of this year. Particular areas of suppliers where we're not being able to pay promptly relate to continuing healthcare and also to the use of agency suppliers. I think I would also then want to just draw out in particular our performance on savings. And Simon, you had asked a question earlier on, which was how have we improved in terms of the identification of savings in month 3 compared to month 2? You'll see that at month 3, we've identified £21.3 million worth of savings that we can assure as amber or green. And that's a movement of £5 million from the position at the end of May, where it had been £16.3 million. So not only during the period of June have we been able to increase the number of savings schemes identified, a chunk of those have also moved into green compared to amber. So there's been an increase in the number of savings identified and a shift in terms of our confidence in the delivery of them. I would, however, want to highlight that that's the in-year quantification of savings, but we are also seeking to achieve those savings on a recurrent basis. And on a recurrent basis, we have not yet fully met the savings target. So we are at £12.1 million worth of savings identified on a recurrent basis. So a real challenge remains for us as a board in terms of seeing that improve up to the £23 million target that we set ourselves. And that's important because it affects our financial sustainability into future years. We have a financial recovery board meeting tomorrow, and a key focus in that will be on the recurrent nature of our savings and also beginning to work on the savings that we need to have actions now to affect years 2 and 3 of our route map to sustainability. So, Chair, conscious of time, I will kind of conclude my presentation on the financial report at that point, but very welcome to take any questions or enter into any discussion or debate on the finance report.
Thank you, Howell. Appreciated. I'll invite Steve to come in, please.
Thank you, Hal. Really helpful report as always, setting out the financial position in detail and very clearly. Some positives to take away as you've set out, an in-month balance position in month 3, and also as you set out a £5 million improvement in our savings programme this month. So that's really good news. But a £1.8 million operational deficit is not where we want to be. So if you could perhaps set out firstly what actions are going to be taken to address that deficit, and also as you've also mentioned, not all the savings programs are recurrent. I think just under 60% are recurrent now. So perhaps if you could say a little bit more about the actions being taken through the Financial Recovery Boards to turn those non-recurrent savings into recurrent savings. To what extent is their challenge, whether the savings could be made recurrent, for example. And then just finally, if you could just say a little bit about sort of what are the factors that may be outside our control in terms of delivering on our financial plan that we may have to just be wary of. I hope that's helpful. Thank you.
No. Thank you, Steve. So taking each of those in turn, you'll see that we've got variance against our budgets in particular areas. Many relate to savings. So the key sort of remedial actions during the remainder of this year will be through our internal performance management arrangements to hold budget holders to account and to expect remedial actions to be taken to bring budgets which are overspent back into balance. In terms of recurrency, the £23 million sort of recurrent savings target that was built into the plan was always a very ambitious target for us, and therefore is in some ways no surprise that at this point in the year it's tremendously good work by the Health Board to be close to finding a full set of savings for this year, but the recurrent aspect was always going to be very challenging. The key actions then to work on that and address it will be through the Financial Recovery Board. Tomorrow there's a particular focus on our commissioning of services where there's a large recurrent gap, and if the next Financial Recovery Board, the focus will then include a deep dive on our provider services, where you'll see in the report it's around the recurrent impact of reduction in agency expenditure, the recurrent impact on reductions in CHC, which will become very important to us as we seek to achieve financial sustainability. In terms then of risks outside of our direct control, I guess a key one which we have an influence on would be in relation to the pathways of care that are delayed in terms of patients not being able to return back to their homes or back to residential care homes in terms of the healthcare system, and the joint work that we're doing with Powys County Council to improve the flow of patients. And then secondly, everyone will be conscious from the news in terms of what's happening in sort of globally in terms of economic terms, and we're not immune to the impact of inflation and the impact of wars around the world and how that could affect us financially going forwards. So I think those would be two key risks which are outside of our direct control in some respects that I would highlight.
Thank you. Could I just come back on that point you just made in terms of the sort of global impact and inflation? Is that something that's being recognised at a Welsh Government level at this point in time?
I guess at a Welsh Government level it's acknowledged, but the expectation is that we would be able to manage our financial plan with the risks which will always accompany it.
Thank you.
I'll bring in others. I may just ask a question myself, building on Steve's area of questioning, but let me bring in, please, Robert.
Yep, thank you for the presentation, Howell. Two quick questions from me. First of all, Grant Thornton made suggestions on saving money on commissioning. When will we be finished testing out some of these proposals? And could you remind me, have we included any of their suggestions in our savings plan for 26-27? And then secondly, slide 6 refers to an underspend by JCC, yet the minutes from the JCC from the 23rd of March refer to an additional financial requirement of 16.2 million in year. Will the JCC cost us more this financial year than originally included in our budget? And if so, how much? Thank you.
Thank you, Robert. I will probably draw on Nicola to come in respect of the work with Grant Thornton and commissioning, and possibly also with respect to the JCC as well, as she's the key link to them. But what our financial reports reflect is the reporting from the JCC finance team. So at the moment, they're reporting an underspend, which is reflected in our report. But Nick, over to you in terms of our work with Grant Thornton in respect of our commissioning of services.
Yeah, thank you, Robert. So the savings plan is based on our own learning, the work we're doing through Better Together, and the recommendations of the Grant Thornton report. Now, there is a bit of a Venn diagram of those two things with some overlaps, which through the development savings programme, we have straightened out as well to make sure that we're not double or triple counting any of those benefits. I'm just trying to remember the 6 or 7 areas they talked about. Can't remember them all, but they are all mapped into there. Things like not taking growth as inevitable. Obviously, our Better Together work on planned care, UEC, and our work on contracting plays into that space. Some of other transformation elements around referral management. And specific schemes like MSK and community health pathways also play in there. Elements around contracting. So we are using some of the NHSE contracting levers like flex and freeze again this year to make sure that we're using those. And other smaller areas such as clinical validation and other things are all mapped, and INNU are all mapped through. You asked a question about when we will have finished testing ourselves against that. We are doing a lot of work on improving our use of data, our operating model for ourselves as a unique commissioner provider in the whole of the UK, actually, as well as in the NHS Wales system, and continuing to do work to fully realise the benefits of the use of contracting levers. Realistically, that'll definitely play still into 27-28, may play into the first half of 28-29. They use the strapline becoming a more mature commissioner, and as you can imagine, that takes time and a lot of skills development and change of processes as well. But we have certainly maximised the opportunities that they described into the savings plan in 26-27, with, as you've heard, a degree of success in terms of developing those plans. On the JCC specifically, at the moment, so there were two parts of the financial commitments to JCC. There was the plan as agreed, with a small uplift over and above what we were, all health boards were funded for. As percentage, I think it was about 1%, just over 1%. So on that plan, as agreed, the JCC currently is balanced and forecasting that they will deliver within that. There was a second part agreed for them to do everything they can to mitigate that 1.1%, i.e. in effect, if they could spend less than that and develop savings schemes not to spend all of that, that's the basis the plan was agreed on for them to do everything they could. They are starting to move into that territory. and there may be a benefit of that to all health boards, including us. But I think that's too early to call it at the moment, and we'll have more information on that in September.
Thank you, Chair.
Thank you.
Thank you very much. So we will now invite Ronnie to contribute, please.
Thank you very much. Howell, as always, a very helpful finance report. Thank you. I think it's very clearly set out. You make the point that we are 1.8 million off profile, and you've referenced issues such as agency and CHC. I suppose I was just wondering, against the background that Pete is now acting chief executive and you're acting director of finance, given the assertive nature that will be required to achieve cost savings, I won't say aggressive, but assertive, do you need extra support in the finance directorate at the moment, which would aid you in achieving those savings? That's my first point. Second point is you referenced the 9.5 million budget available in capital and said that you're confident that we can spend it this year. Normally we do spend our full allocation, but I just wondered if there's anything which might have the potential to derail us there. Thank you.
Ronnie, thank you for your questions. I think I would start by saying, the executive team as a whole are united in terms of trying to identify the savings and achieve the plan that we've developed, including the financial plan. So it's incumbent on all of us in terms of that, and that's what we're seeing. We do recognise that I'm substantively the deputy director, and therefore at the moment there is a vacancy of a senior person in our team. We've got an advert out at the moment for attract somebody to come in on secondment to join the finance team to bolster then the financial capacity that we have, particularly within that function. In terms of capital, as you say, each year we do fully spend to our capital programme, and actually this year some of those monies are for work in Llandrindod Wells, where actually the expenditure is likely to happen prior to Christmas. So we may actually spend more of the capital monies earlier in the year than we might have done historically this time. Pete, did you want to come in at all in terms of sort of our financial capacity and the challenge that we have in terms of delivery of the financial plan?
I think you've covered it perfectly, Howell. But yes, Ronnie, really good points. Appreciate the questions. As Howell has said, we're making sure that we do cover that backfill as needed to maintain the focus. Our financial recovery board is the number one mechanism in terms of our overall whole exec team and whole organisational focus on all the actions we're taking to deliver against our plan and our targets. So very mindful of it, very focused on it, and as Howell said, it's an area of determination for us all.
Thank you. Ronnie, you content?
Thanks, Carl. I am indeed.
Okay. So finally, we'll ask Mick to come in, please.
Thanks, Chair. Thanks, Al. I appreciate it's early in the year, and the month 3 outturn is quite encouraging. But reading the report, as Ronnie said, some of those pressures that we're dealing with are very familiar. So agency spend, CHC, the savings plan. So as a question, as I read the papers, what's materially different this year that gives us confidence that we can maintain that forecast position? And I suppose linked to that, as we move our way through the year, what are the key signals or the key signs that would suggest to us that we need to change course or consider additional action to get to control targets at year end? Because I would just suggest that, in our current operating context, not delivering against the plan that we've set, which is not accepted, as we know, I don't think in reputational terms that's something that we can contemplate. So just like very reassurance that this year is going to be different, and we understand when is the time to contemplate a different course.
Yeah, thank you, Mick. I think I would draw upon our track record as an organisation in terms of achieving the plans that we set for ourselves. There had been a sort of an exception last year due to the price increases that were unexpected in the English system and unknown at the start of the year. So I think that the first point would be around the arrangements that we have established to manage our finances and monitor them, enhanced this year by the establishment of the Financial Recovery Board from April, which is enabling us as an executive team to devote more time and focus into the operational actions that then enable us to constrain our expenditure. I'm sorry, I think I've forgotten your second part of your question. Sorry, Mick.
I suppose put simply, when is the time to start worrying, and how would we know?
Yes. Okay. Yes. And what are the key indicators? So you'll see within the finance report that we try to look at those indicators which have a financial impact. So for example, the number of CHC packages and the number of days of CHC, that's an important indicator of our expenditure in that area. Similarly, then the number of vacancies that we hold, particularly I would draw out the number of medical locums that we currently have and the vacancies that we have there. That's another key indicator for us in terms of whether we're achieving the savings that we have planned. But for the moment, we have a strong portfolio of savings that are set out. We will regularly monitor against them. We're £1.8 million off profile, which occurred in the first month of the year. So we should expect to see that reduce coming through into the autumn. So I guess as in most years, we kind of do take stock in the autumn to see where have things got to after the first 5 or 6 months of the year.
Okay, thank you, Carl.
Thanks, Mick. So thank you, Howell. And just building on colleagues' questions and comments, and I think you have given us very helpful assurance in relation to both where we are financially and what we can expect to happen over the next weeks and months. I think as colleagues have said, we do need to rally around a shared commitment to delivering the plan that we agreed, albeit not a supported or accepted plan with Welsh Government. The plan stabilises our financial position. It doesn't improve it. Even in delivering the plan, we have a significant deficit position, but also acknowledging that it is a very ambitious plan, and in delivering the plan, we will once again have achieved another set of rather eye-watering savings as an organisation. And so, but nonetheless, I think we do need to coalesce afresh around that unequivocal commitment to delivering the plan that we agreed. So thank you, Howell, much appreciated, and please be assured and please convey to your team our appreciation and support. So colleagues, in relation to the financial performance report, we are asked to receive the report, to take assurance that our organisation has effective financial monitoring and reporting mechanisms in place, and to consider and discuss the financial forecast and the underlying deficit for 26-27 of £44.652 million. Once again, does anybody want to comment? Does anybody want to indicate that they don't support the recommendation? That too, therefore, is supported unanimously. So it looks like our meeting is going to need more time today than we had originally scheduled and anticipated. We will work out that, and we will come back after lunch with a rejigged, if you like, timeline for this afternoon, but it's clear that we're not going to conclude our in public board meeting business before lunch. So we will take a lunch break now, and we will come back in half an hour's time. So at 13:35, and we will then deal with the remaining items on our in public board meeting before moving into our in private board meeting. So see you in half an hour. Thank you.